Morning, everyone. It's a great pleasure to be here. And like Walter said, he's part Rwandan. I'm also part Rwandan, I guess. But I think it's wonderful that, for such a great occasion like this, the Global Healthcare Summit happening in Rwanda, there is such a beautiful mix of nationalities here. There is a special connection between Zimbabwe and Ghana, and I'm really glad that we have been able to bring this relationship together at this function. So without much ado, I'd like to welcome our honorary guest and host for this two-day function, Dr. Sabin Nzazimana, who is the DG of the Biomedical Center here in Rwanda, to give us his opening remarks and welcome. Doctor, please.
Thank you very much. As you rightly said, Ghana, Zimbabwe, Rwanda, all the corners of Africa and beyond. We are all part of one global health. And it's my pleasure to be here today to have this conversation, which is very timely because of what we're going through since 2019 with this pandemic that has demonstrated the importance of working together as nations, as experts, to improve the health and the lives of people. So I don't have difficulties to explain how it is a challenge, but it is also an eye-opener or an opportunity to see how best we can be more and more together as a global team to improve health systems, health programs, healthcare. So when COVID started and borders were closed, no airlines moving, and actually no supply chain happening even for health essential products, that is the first time personally I started to see how no single nation or country in the world can manage itself something like that. Even the most rich countries can't. Because these viruses and microbes and diseases do not respect any border. They don't travel with passports or visa. Sometimes they take the opportunity of people moving. And they don't respect the principle of single regional health. So if viruses respect the principle of global health, why don't we do the same? So today, as we meet and discuss over the next few days, I want to pose a few questions for reflections, but also to see how we don't just reflect, but also act and make changes. Today, global health is clearly a priority now. When this principle has been discussed like 4 or 5 years ago, I started to see programs created in universities, in countries on global health. Some people thought it as just isolated initiatives here and there. this pandemic was coming to confirm that what has been started 5 years ago, even before, was very necessary. And actually, we delayed to start that principle and even to apply what was needed, which is health is not just an opportunity or luxury or a negotiation. It's a human right. Accessing health and quality health, not just the cheap service or the cheap health care. So that is something I learned over the last few years, and it was emphasized in the last 1 year and 8 months that we went through this pandemic. So that was my number 3. Health, access to health. It's a human right and shouldn't be denied or negotiated. So in Rwanda, we've experienced at different times the importance of health and the lives of people and how health systems are very important. There are 2 important events that happened. One, 27 years ago to be precise. Another one is ongoing. 27 years ago, there was a genocide, I think everyone knows, against the Tutsis in Rwanda that took 1 million, at least 1 million lives of people. But the health care or the health systems was affected during that period in a particular way. Let me cite 2 statistics. Number 1, 80% of healthcare workers were taken out of the system. 80%, 80. Part of that were people who were killed. Another part were people who killed them. And another part were doctors and nurses who were no longer capable to offer care because of what they have seen, because of post-traumatic syndrome disorders, because they have been treating patients, and then when the patient recovers just a few minutes later, the same person who just cared is killed in front of you, in your eyes. In big hospitals, most doctors who are in this room may know these are true stories. So 80% were no longer able to offer care in just 3 months. So the entire health system of a country was managed by 20% of the healthcare personnel in a country of closer to I think it was about 9 or closer to 10 million people. Only 20%. And yet, even the 100% that were there before are not enough. You lose 80% of those. So rebuilding a country or a health system from almost zero was the biggest health challenge that the world has ever faced in any nation. And that is a true story, just 27 years ago. What happened between then and now was to catch up with the 8%, and I'm talking about people. I'm not talking about infrastructure, because that was even worse. And I'm not talking about diseases, because diseases were even more and more. The more people exposed, like diseases like HIV, like TB, that was the opportunity for those viruses and microbes to spread even more, malnutrition. You can imagine all the challenges of health that can happened. So 27 years later, through the process of recovering and rebuilding that health systems that was attaining a very interesting level when people are no longer dying from those infectious diseases, when people can access health without paying the fortunes of an entire family because of universal health insurance coverage, and when doctors were transferring skills to community health workers all around the country. We can't train doctors in one day, but you can train community health workers to manage 60% of malaria cases. That is a fact in Rwanda. So those are the kind of initiatives that were happening 27 years through the process. Most of you, I see, partners in different organizations, institutions who have played a role into this journey. So last year, on March 14, we confirmed what was going to be, to us, of course, because it has started somewhere else in other countries, to be another second, not the same magnitude, but worldwide. It's something that has not happened over the last 100 years. An entire generation never saw what we've seen since last year. When people can't move, when even goods can't move, when you have to stay home without even going to see your neighbor, your family, your mother, your children. And it's not yet over. So in Rwanda, when we saw COVID pandemic coming, in the health system or healthcare, we were thinking about the history of what we went through and how we're going to tackle this challenge yet to be known, because science was very limited. And we had to convince ourselves that this is a serious threat to our health system that was still recovering, rebuilding. But we must stand strong and face it. Although we couldn't get even masks, even those that we had purchased, and the money was sent, but at the airport, some countries are saying, no export, nothing's moving. That is a reality that happened in March last year. We purchased 3 million masks, and at the airport, they said, no, nothing is moving out of this country. Then we couldn't get the masks. Vaccines, we purchased 500,000 vaccines sometime beginning this year. And at the time of delivery, said, no, these vaccines are not living here. We're dealing with our own problems. Until now, the vaccines are not here. And the money is not yet here, back. So this is to tell you how the challenges of the health, of global health, still exist. And we should take a step to see the reality and face it and work as one team. Because the virus seems to be working as a great team. But humans and experts, I think we still have a lot to do. So a few things that to close my few remarks. What have we learned from all this journey, 27 years, or at least the last almost 2 years? Number one, leadership. Leadership has played a big role, and you have very clear examples. When leadership was firm and strong, even without money, without a lot of money, billions. without billions, without millions, without masks, without factories, you can do something. And leadership that has everything, but that can't be used properly, was also catastrophic. So it's not about the things, it's about how the people organize the response. Number 2, partnership. Although there are challenges here and there of lack of partnerships or working together in science, in diplomacy, but they are very good examples of great partnerships. Our first lab that was able to test COVID very early, I think was the first or the second in Africa to have that capacity to test COVID last year, was possible because of partnership. We made a call to our colleagues that we need to test, but we have no capacity, we have no test, we have no kits. And it took just 4 days to have experts in our lab with kits in their luggage, in their bag, training 12 of our staff. And day 5, we were testing COVID. That is how it started. That is a good example of great partnerships. Number 3, science and data. Since COVID, we learned that without the love and the interest in science and generating real-time data, it's very hard even for the leadership to take good decisions. So this has been mentioned in many conferences, many meetings, that science, let's invest in science, then it became as important. But when COVID came, it demonstrated the lack of those tools that are very important, and you have to get that because you needed it. How many people have COVID? How many people are, where? Who is dying? Why? How can we, those are the questions that we are all asking. Even those non-scientists were asking, tell us data. This evening, have you seen the report? How many? Those are questions about data and science that global health needed, regional health needed, local health needed to make good decisions. So denying science or data was a kind of working in the dark or eyes closed. But this is a lesson, and I think it will continue to guide us forward. Number 4 is innovation. We've learned in many books that this is how things work, but in real life, it's totally different. Sometimes the opposite. Because people live in different periods. If the books we used in medical school were written in 90s, that time there were no COVID, no pandemic. Today, if you apply the same principle of those books today, you'll be very wrong. Because these are different generations, different challenges, different diseases. There was no internet, there was nothing. There was something, but now we are in a different period. So innovation to me is applying those solutions to the current reality. And it could be a different reality from Europe, from America, from Australia, from South Africa, so each country has its own reality. And we shouldn't be applying the same solutions always. The goals can be the same, but the process do not necessarily be the same. Because the populations are also different, behaviors are different. The last one, but not the least, as a lesson is that it's now clear investing in global health, in health systems, it's a priority. Even the finance people are repeating this many times. There is a time we're asking in Ministry of Finance or with different finance organizations, can we have some money to buy some medicine or build a lab that will help us to know the diseases? Say, it's okay, but let's just finish that road or just that school. School is important. But when the health system or global health is affected, everything else is affected. But at least this is something we all now agree on. I hope it will continue. It will not be the hard job of doctors, experts in global health, to convince the finance and money people that health is important. Now everything sees that. At least 99%. Maybe the 1% who still believe that it will be a miracle somewhere. So these are the lessons I think we've got from this journey. So today, as we look back, but also thinking in the future, what should we do? There are probably a few things, just that will be the end of my talk. Number one, what we'll do tomorrow is determined by the evidence and the data we have today. But what we'll do tomorrow is different from what we're doing today. So if we think that it will be the same, it's a mistake that we should correct right now. Number two, this pandemic has affected global health. Seriously, it's not over. And it's not the last one. What we must do right now is to build strong capacities to be ready when this pandemic continues or a new one much severer is going to happen next. Because there are so many threats. Some are depending on our behaviors, environment, or animals, and this is One Health principle. So this is the time in the military when there's ceasefire, that is the time they prepare for the wars. That is how they build the army, the training, they buy equipments, they do diplomacy, they do a lot of things. So we are not in the ceasefire per se, but at least the example of Rwanda with current positivity, at least I would say that this is a good time to be ready with a more wave coming next, with more serious viruses coming next. So apply it to the world. Are we working together better than before? Are we doing more investment in health and science than before? Are we prioritizing health than before? Are we considering health as human right as before? So this is what I think we could be debating and discussing if we want to be ready for next pandemic. Thank you very much.
Thank you very much, Doctor. Thank you very much, Doctor. As I was listening, Doctor, in Zanzimana, it brought about the stark, what he did give us, the stark reflection of, where the government of Rwanda and the people of Rwanda have come from 27 years ago. He's also told us about the development that, the government of Rwanda has made towards healthcare, He's talked about the impact of COVID-19, but he also left key points that I just want to reiterate before I call our next speaker. And I think primarily is the fact that healthcare is not something that we can look at as individuals. There is a global connection between everybody sitting in this room, all the categories that we are coming from sitting in this room. The fact that, the people of Rwanda have built their health system from ground zero is an important determinant of where everybody globally needs to go. I particularly like the lessons that they have learned around leadership and the organization of people, because policies cannot be implemented in a vacuum. They need people behind them. You talked about partnerships, and I want to believe that this partnership is also reflected in the participants sitting in this particular room today. He talked about science and data to help make good decisions, to help have a vision for planning, implementation, and monitoring. And he talked about innovation. And the very fact that solutions from yesteryears cannot be applied in detail, but have to be looked at with the realities of today and the environment that we are in. I particularly like what he also said about the pandemic affecting global health, and that the need to build capacities against so many threats. Critical among them would be our own behaviors, the environment, and animals. And the fact also that now, 2021 November, is the time to build back, to build better, to plan towards a recovery, building of the systems, to invest in science and health. Thank you very much, Doctor, for those insights, which has set the tone, actually, for the rest of our conference. So now, I'm going to ask Dr. Brian Chirombo. Is he? Oh, okay, sorry. The representative from the WHO, a critical partner in global health, a critical connector for global health, to come and give us some opening remarks. Thank you very much. Madame Diopista from the WHO. Thank you very much.
Thank you very much for inviting WHO to be part of this gathering. I'm representing Dr. Brian Chirombo, the WHO representative for Rwanda. Unfortunately, he was called in another engagement, so he could not be here to deliver what he was planning to do. He has asked me to share a few slides on the global health. If you can project the slides, please, for me. Okay, maybe I should continue while waiting for the slides. As Dr. Saben said, the pandemic is still here with us, and we still have a long way to go in order to control it. We are almost 2 years since the first case was of COVID-19 was reported, and we have globally experienced around 250 million cases, which has been reported to WHO, and more than 5 million deaths has been experienced and reported to WHO. And more deaths has been recorded in people who have comorbidities. And as you are seeing from the slide, we have experienced different waves. And unfortunately, I was expecting to be shown in a larger screen. All the regions from Europe, Africa, Southeast Asia, they've been affected. And this slide shows the African region. In the African region, you can see that we've been having 3 distinct waves. And the last wave, which in the last wave, which is now decreasing, but it was very severe in July, August, and now it is getting down. And we are reporting cases even lower than the numbers which we experienced when the COVID-19 started in March 2020. And in the African region, we have recorded about 6 million deaths. On the vaccination, vaccination remains a vital tool and a new tool to strengthen the other public health measures. And globally, there have been 7 million doses which have been administered. But when you look at the Africa, we are still having lower doses which have been administered. And this poses a great inequity in accessing the vaccines. And we cannot end this pandemic with this situation. We needed to ensure that we ensure the availability of the vaccines throughout the world, to the, especially in the African region and the other lower and middle income countries, which have got low capacity for production of the vaccines. And globally, WHO and other partners, they started working on ensuring the equity in vaccine through the establishment of the COVAX, although there are still some challenges. And the uptake in the African region for the African countries, it has been good. However, we still have some countries which are still not able to absorb all the vaccines which have been available to them. So the issue of absorption capacity comes in. To increase the vaccination coverage on the continent, WHO and partners are helping countries to identify the gaps and try to address them. And here I would like to commend the government of Rwanda for being among the countries which have been put in place measures to absorb all the vaccines which have become available to Rwanda and ensure that everybody who is supposed to get the vaccine is getting it. WHO, in collaboration with the partners and the national governments and researchers, have been monitoring the different variants where we need the science so that we can be able to track which variants are coming in, where are they, and how can we put measures to mitigate them. And the major variant which has been reported is the Delta, which has affected most countries and increased the vulnerability of the countries. We have noted some challenges which need to be addressed in the global pandemic response. Just to add on what Dr. Sabine was saying about the multi-sectoral response, we are still having challenges in the multi-sectoral response to ensure that all the pillars of the response are addressed. The leadership is critical to ensure that all the governments in different countries at local levels we have leadership to ensure that we address the pandemic and institute the measures to address them. There's been limited funding globally and in the countries to ensure that the measures which are put in place, they are addressed adequately. There's been inadequate public health awareness and non-compliance to the public health measures to ensure that we mitigate the pandemic. And again, as I said, there have been lower vaccination coverage and the vaccine hesitance, of which we really need to address and strengthen the way we address the measures. Of course, the limited capacities of the health system to be able to respond in different aspects of the pillars, including case detection, strengthening laboratory capacity, case management, surveillance, and data, so that we know where is the virus, what needs to be done, and how best to address them, and again, to strengthen the communication system. There is also an important pillar in this, which is continuity of essential services. Yes, continuity of essential services. In most countries, we've concentrated in responding to the response and forgot about the other services. And the impact of the COVID-19 has shown that we really needed to strengthen and have the resilient system, which we can continue while responding to the pandemic and at the same time ensuring that essential services are continuing, especially when you look at there's been reported services which have been affected. For example, in this graph, it shows that WHO has been conducting what is called pulse survey in countries, and so far there have been 2 rounds. The first round in 2020 and the second round early this year, and it has shown that the services have been affected. Although we are now in the second round, we noted that there's been improvement in a number of services which were affected in 2020 and 2021. So we really need to strengthen the system to ensure continuity of essential services, for example, the immunization services, services to women and children, services to people who are on ART, malaria, TB, non-communicable diseases. We really need to ensure that these services are continuing while we address the pandemic. High-level advocacy and governance is important, especially to ensure that there is a holistic approach for addressing the pandemic and at the same time strengthening the system. On the vaccination, yes, vaccination is a critical tool, but still we need to ensure that all other public health measures are in place. Can you go to the next one, please? All public health measures are in place, and there are proposed actions which we can undertake. For example, the first one is to ensure that we strengthen the response throughout the pillars, ensuring that we strengthen the public health measures, we ensure availability and uptake of the tools and services, we ensure strengthening the data systems so that we can know where the viruses are, and also ensuring that we have strengthening capacities to respond to the pandemic in all aspects and ensure continuity of essential services. Next. On the use of vaccine, we need to ensure that we advocate for availability of vaccines throughout the countries and ensure uptake and address the vaccine hesitance so that we can be able to use this tool effectively to respond to the pandemic. And last, we need to strengthen the preparedness, global preparedness and response for the pandemic, and at the same time strengthening the health system resilience to be able to deliver other services. Next. I would like to end this talk by reminding ourselves that the pandemic is still here with us. Yes, we have the vaccine. We have been vaccinated, although not all of us, but this needs to go hand in hand with other measures, public health measures. We needed to ensure physical and social distancing. We needed to ensure we wash our hands. We needed to ensure we have our masks, and we needed to ensure that we continuously provide awareness messages to our communities so that we are able to mitigate the impact of the pandemic and at the same time address the essential services. I would like you to end here and thank you for this opportunity.
Thank you very much, Madam. Another round of applause, please, as Madam takes her seat. Thank you. So, okay. It's a public announcement first. I understand there's a vehicle, registration number RAE 786D, that is blocking the route. So if there's anyone here with that vehicle, could the person kindly step outside and sort it out? So thank you very much, Madam. Thank you very much. So sorry about that. She's given us a very, very good picture of the health statistics that Dr. Nzimanana spoke about. That is very, very vital for decision-making and planning. She's given us some ideas about how the WHO over the last 18 months has worked hand in hand with our national governments to look at the 3 consecutive waves of COVID on the continent, giving us an idea about the vaccine availability, its absorption capacity, and actually some statistics also about the vaccine hesitancy that is prevalent in a lot of the countries that the WHO is working in. She's highlighted the importance of a multi-sectoral approach to addressing not just the pandemic, but the very fact that research had shown that in addressing the pandemic, other sectors of the health sector were neglected. We're looking at MCHN, mother and child health. We're looking at immunization services. We're looking at reproductive health in general. And I would add, because of where I work, in terms of water, sanitation, hygiene, that is so critical to any health outcome that we're all fighting for. She's talked about needing a systemic approach, a holistic systemic approach to strengthen pandemic response and overall, to improve the health status of the populations. So without further ado, I'm going to ask Dr. Dhiren Thakur, who is the MD of Meditas, the founder and CEO of Meditas, to come and give his opening remarks. Thank you, sir.
Thank you, Madam, for the introduction. And good morning to everybody. I would like to start by thanking the organizers, specifically Ms. Memory Uzaman, for all her efforts in getting us all together for this very important event. My main motivation to come here at this conference is to convey my thoughts on the very important issue of poor access to medicine in sub-Saharan Africa. We talked a lot about COVID-19 and how it has uncovered some of the major faults in healthcare system. But I'm here to tell you that the access to medicine and the problem with access to medicine goes back a long ways. What COVID has done is simply uncovered how important the problem is for us to face. And I'd like to really talk about this briefly today during the question and answer session and then in tomorrow's morning session. And also share with you the initiative that, that I have started, and that is to forming a nonprofit called MedEditus, with a major mission to work towards improving access to medicine in parts of the world where the need is acute. And we are specifically focusing on sub-Saharan Africa. But to really set the stage, what I want to do in my opening remarks is to just give you a brief background about myself and my motivation for starting MedEditus. I have had a long career in pharmacy and pharmaceutical sciences, nearly 50 years of a career, starting with an undergraduate degree in pharmacy from Bombay University. And then I spent nearly 50 years in the United States, where I got my higher education, got my PhD. I have worked in National Institutes of Health, US FDA, Glaxo, which is now known as GSK. And then last 25 years, I've spent at the University of North Carolina at Chapel Hill in the School of Pharmacy. For those of you who are not aware, University of North Carolina at Chapel Hill, which we call UNC, is the oldest public university in the US. It's nearly 225 years old. And the School of Pharmacy, the Eshelman School of Pharmacy, where I spent this time, is the #1 school of pharmacy in the US. At the School of Pharmacy, I have been distinguished professor, teaching, training students for PhD, postdoctoral fellows, conducting research and publishing. But I also have sort of served in different leadership roles, including ultimately I was the interim dean of the school. But the one area of my leadership that I want to highlight is knowing that I think as the Director General of RBC indicated, really we cannot be isolated. We have to be thinking about ourselves as global citizens, particularly in healthcare. So with that mindset, in fact, I started an Office of Global Engagement and developed many strategic partnerships between our school and academic institutions, government, in different parts of the world. In fact, one of the programs that we initiated called Global Pharmacy Scholars, through that program, we are sending final year Doctor of Pharmacy students to different parts of the world for service learning mission. They go to countries where healthcare is well developed, but they also go to countries where healthcare is severely lacking or under development. And the goal is for these young professionals to really understand really the status of healthcare in different parts of the world and not just think about North Carolina. And I can tell you that, and I was one of the architects of this program, and in fact I have started an endowed fund to support that, I and my wife. But the students who have come back from this have expressed how this has changed their mindset, their life, their plan for their professional career. So it is really important for us to really get our young professionals, our students, our young graduates, to help them see what is going on in healthcare in the world. And I encourage those of you who have ability to really, support that kind of program to really do so. So during this, my sort of a role in global engagement and other leadership roles, I think I began to appreciate that healthcare in general and access to medicine is very, very different in different parts of the world. What we take for granted in the U.S. Is a major problem in many parts of the world. Getting even simple, access to simple medicines. And having spent my career in pharmaceutical sciences, in fact, contributing to discovering and developing new drugs, of course, I've studied what medicines can do to humankind. And really, discovery and development of new medicines have literally lifted the lives of people. Medicines really have contributed to increasing lifespan by decades in many of the countries. And those countries that do not have access, that elevation in lifespan is actually still lacking by many decades. Not only that, but pharmaceuticals and medicines actually can also contribute significantly to improving the quality of life, which is as important as sort of how long one lives. Knowing this, and knowing that the access to medicines is a major problem in many parts of the world, and not just simple access, but even bigger problem is the spread of falsified and substandard medicines. And that's actually in many ways even worse than not having medicines, because people go to pharmacy, get medicines, thinking that they are treating their ailment. But what is happening is they are under a total sort of darkness that medicine is doing nothing for them at the minimum, or even causing harm to their health. This has to change. And while pandemic has actually given us sort of insights into why some of these things is happening, I think, at least I believe that the way to bring about this change is not just to strengthen supply chain, from countries where these medicines are produced to countries where it is exported. We must work to build capacity to make medicines in the countries where they are needed. That is the only lasting solution that really exists for us to ultimately have that access, the universal access to the citizens of all countries. That is my belief, and to make good on doing something about this, I have decided, in fact, I decided to retire from my academic career 2 years ago in 2019. And I did so mainly to really start working on this problem. For remaining of my healthy life, I want to really continue to work on this problem. And what I've done is to start a nonprofit called Editus. Editus in Latin means access. So as you can see, the name suggests we want to really work tirelessly to really do what we can to improve access. And because I believe that local production of medicine is an important part of the big solution, what we would like to do is to come to one of the countries. We are looking at Rwanda, we are also looking at Kenya, to come one of the countries and actually start manufacturing of much needed medicines. Not only we want to do that, but we really want to bring the latest technology in pharmaceutical manufacturing that is being developed in the US and Europe over the last 10 to 15 years. I believe, and it is called continuous modular manufacturing, I believe that that technology, if we bring here, and it'll be the first of its kind in Africa, not only will produce medicines that are of high quality and of low cost, but I believe that we can actually show through our, hopefully our success, that this is scalable. You can actually really go from less than 400 manufacturing units in this entire continent and compare that to 10,000 manufacturing units in India with about the same population. So I believe that this kind of technology, if adopted, can rapidly change the scene and actually help us scale this to different countries. We are also bringing digital technology to improve managing the quality data and make it transparent to the regulatory agencies. And by doing so, we can speed up really the approval of new products. So really, we're going to bring a lot of innovation with the goal to showcase that this can be done in these countries and that it can be scaled, and we can actually really go from where we are to where most countries are in Africa importing from 70 to 95% of their medical needs. That I believe we can change that by many fold. So that's our goal, and I look forward to really being part of African community and society over the next few years. Thank you for listening, and again, I can provide more details during Q&A as well as in tomorrow's session. Thank you.
Thank you very much, Dr. Thacker. Please, another round of applause for Dr. Thacker. Dr. Thacker has given us a very good historical background to his life passion, if I may call it that now. His, I think some of the words that caught my mind were the fact that I see him as a global citizen for health. Thank you very much. He's very much interested in capacity building for the future. And that has been seen through the the placement of youth in health condition, in health sectors, and how the fact that these kids have been transformed by their placements in all those places that they have had the experience to work in. I like the fact that he talks about healthcare and access to medicines to support lifespan and the quality of life. He threw a challenge about some ineffective medicines and the fact that medicines, in fact, is not necessarily, the future is not to strengthen the supply chains of medicines manufactured outside the continent, but the fact that we need to build capacity here to bring together affordable, effective medicines on the continent, and that it can be done. He is passionate about the manufacturing of medicine. He's talked about digital technology to support healthcare, and the very fact that this is an initiative that he's passionate about, and this is why he's fundamentally here for this conference. So thank you very much for that, Dr. Thacker. Looking around the room, Dr. Sabin spoke about the partnerships and the leadership that is required to build a healthcare system. And so looking at that, I'd like to invite our next colleague and partner to the podium, Dr. Dirk Duprez, who is the country representative for the Belgian Development Agency. A round of applause for Dr. Duprez.
Good morning, everybody. I have a bit of a challenge here because I'm the fourth speaker making opening remarks, and on top of that, although I'm named a doctor, I'm a lawyer. speaking about global health. I don't want to repeat everybody, but I would refer to our facilitator when he said that we're happy that this conference is taking place after being delayed 2-3 times, because it shows in fact that COVID is still there, but in Rwanda we've seen a lot of progress being made, which allows us to have this kind of conferences again. Unfortunately, as many speakers said before me, it isn't finished, and I can simply refer to what is happening in Belgium. Yesterday evening, our Prime Minister said, all signals are back on red. We've crossed the red line. We have to take new measures. We're back in telework. We're back wearing our masks much more. We've had a representation of WHO in Africa. There's a lot of surges again in different countries. I saw on the African CDC website and their COVID update of November 11 that they say that 46 states are in the 3rd wave, while 9 are in the severe 4th wave. So COVID is still with us, notwithstanding the rollout of vaccines. And we still have to continue playing, in fact, our role in protecting ourselves and especially also others. But I think, indeed, COVID somewhere is a bit a game changer, even if it's maybe stressing, indeed, as Dr. Tucker mentioned, some discrepancies which were already existing. First of all, there was indeed, as already mentioned by Dr. Saban, the fragility of the global supply chains. When the manufacturer of the world in Asia went in lockdown, it had and continues to have effects on global supply chains, hampering the economic recovery, which is even more needed now, where we are slowly going back to more as normal. But I think the most striking element remains for me the very relativity of our global solidarity speeches, because what we saw, in fact, is as soon as the pandemic started, is a bit, it's normal, I think, that governments want to protect their own citizens first. But what we saw is that, in fact, we almost fell back in the struggle of the fittest. Access first to personal protective equipment. We all heard these stories of one country buying, in fact, what was already bought by another, but just simply paying more. Borders being closed because we wanted to keep the goods for ourselves. First on the personal protective equipment, and today still, in fact, on the vaccines. While at the same time we all are recognizing, and it's all in all the speeches we say, none of us is safe until we are all safe. But I think we still a lot more has to be, and can be done on that. And on the access of vaccines and the rollout, I think, and maybe I take a bit of a sidestep here, but I really would like to use this occasion also to express my recognition to Rwanda Biomedical Center as a whole, to the Rwandan government, to health workers here, to local government security staff, because I've been living in Rwanda since the beginning of the COVID pandemic, and I think the measures being taken here are exceptional, and they really have, lives have been saved. Just to show it then a bit objectively, not to have it only me, Rwanda was at a certain moment the only country green to travel to Europe. While in Europe we were not allowed to travel from one country to the other because we are orange and red. So I really would like to applaud for this RBC and the government, because it was really an amazing job done. And I agree with Dr. Saban, because this was only possible because there was 27 years of investment in strengthening the health system. There was a strong basis which made it possible. But at the same time, we must recognize that we didn't make it easy to Rwanda. Because even now, if we say the rollout of vaccines, I think Rwanda is, Kigali, we are at 90% of vaccination. Countrywide, 50% have had their first dose, if I'm correct. It's amazing. It's unique, but it's an exception in Africa. And we made it difficult because many of the vaccines which arrived were almost at the end of their shelf life. So putting an extra stress from, okay, you get vaccines, but you only have a few weeks to get them out. And now today, yesterday we received a mail from UNICEF saying that at the moment there are not enough syringes anymore. So there are more vaccines coming in than syringes. So these problems of global chains and solidarity continue to play, even in countries which are doing all their best. As I mentioned, Rwanda is maybe a bit of an exception still, and I read on the World Bank website that in the low-income countries, only 2% of the population really has had access to vaccines, which is incredibly low, and of course continuing to stress the health system, but also the economic recovery. Now, different initiatives are on the way, and it links a bit with what Dr. Tucker mentioned. There is this partnership for African vaccine manufacturing. There are large commitments, presidential commitments. Ursula von der Leyen, President of the European Commission, announced that Team Europe, and Team Europe is the European Union plus its member states, are committing €1 billion to facilitate manufacturing and access to vaccines. Other donors like USAID, MasterCard Foundation are all saying they are willing to support this local manufacturing. And I think that this strong political will, both on the African side as on the development partner side, linked with the launching of the African Continental Free Trade Agreement, it offers in fact a unique opportunity for investors and for businessmen who want to grab an opportunity to step into vaccine production and medicine production in Africa. We have heard also the announcement of 2 plants that will be opened by BioNTech in Rwanda and Senegal. I think these kids can really be game changers, but they are not enough. More is possible. And well, Dr. Tucker already spoke about it. Beyond COVID, the need and the potential to assure access to essential medicines is enormous. And when I reread a bit the Team European initiative on supporting local manufacturing, they refer to WHO data, that 2 billion people globally have no access to essential medicines. 2 billion. It goes about antimalarials, antiretrovirals, drugs for maternal and reproductive health, pediatric medicines, which are either not available or unaffordable, or, as Dr. Tucker mentioned, low quality. Now, we can look at it from a human rights perspective, and of course, if you want investors, we should also look at the benefits from it. And there again, I was surprised, because we hear indeed 99% of vaccines imported, but also 94% of medicines. And a study from 2020 from Goldstein Research mentions that they estimate the pharmaceutical market in Africa to be $28.5 billion and to double by 2030. It's enormous. So it's also a huge opportunity for investors who want to step into manufacturing. And I think we have today, maybe we can say between brackets, thanks to COVID, but an exceptional window of opportunity to step into it. Governments are willing to support, development partners are willing to support. Team Europe in Rwanda is already working with Rwanda Food and Drug Administration to strengthen the national regulator, but we want to do much more. We're talking about willing to support access to finance, to have guarantee funds, to look at possibilities to further de-risk by also training the needed staff to put more focus on the necessary TVET, but also the university studies. And university trainings, we should go out hand in hand also with increased research. Because sometimes one of the doctors, I'm a lawyer, then told me, well, there are a lot of these forgotten tropical diseases. Maybe forgotten is a bit a cynical word for saying they were not considered profit-oriented enough for big companies to invest in. But I think that local research in Africa can bring in a response to tackle these tropical diseases. But local production can also tackle the affordability. I think Dr. Tucker also already mentioned it, but we see also an evolution in the public health challenges with urbanization, with a growing middle class, more and more non-communicable diseases, people needing medicines for high blood pressure, diabetes, cardiovascular problems. A lot of these medicines are already patent-free and can be done on a generic way, and can probably be done at a much lower cost locally than being imported. So I think there is really a potential here for a win-win, and that's because you can say, why do I talk about this here? But it's simply when I looked at the small document I found, the warm welcome note for the Global Healthcare Summit. I read about it from, we're going here to discuss global health delivery, new ideas, digital innovation. But there's also an important line on saying opportunities to forge business relations. And what I would give as a bit of takeaway for everybody here is, please go beyond the normal buy and sell. I think Dr. Tucker's initiative is very applaudable. I think there is really an opportunity there to go further. And I really would like you to invite in your discussions, in your networking, discuss also the possibility of bringing manufacturing to Africa to help responding to not only the health crisis, but also to respond to job creation and wealth creation. I wish you all 2 days of a fruitful summit and interactions. Thank you very much.
very much, Dr. Duprez. Another round of applause, please. I think we have to thank the organizers for the way they lined up our speakers for this opening ceremony. We started off by having the DG himself from the Rwandan Biomedical Center setting the environment, setting the space, setting the tone. Then we had, okay, let me start with Dr. Duprez and Dr. Thacker talking about manufacturing. And I think Dr. Duprez's final comments about the opportunity to develop a market for local products here is big. The fact that he's coming from a development agency and speaking so encouragingly for private sector to get involved in this is wonderful. And I think it links in directly with what Dr. Thacker was talking about as well in terms of producing local medicines that expand lifespan and bring quality to life. I like particularly what Mr. Duprez mentioned in terms of building a capacity for research into tropical medicines, research to tackle affordability for the local African population. And the fact that, statistics show us that there is a rise in non-communicable diseases, diabetes, high blood pressure, and the medicines for these, diseases can be produced locally and more affordably. He mentioned statistics that blew my mind. You mentioned $28.5 billion as market opportunity for medicines here just on the continent. And so this is a real, what do I want to use? A throw out to the private sector to get involved. Private sector, of course, in close relationship with the governments on the continent. I think Madame from WHO also talked a little bit about the challenge of vaccines and the fact that both Senegal and Rwanda are scheduled or even started producing vaccines is a big plus. And I think it's leading the way for other governments on the continent to do the same. Walter, I think we've come to the end of our opening ceremony. We've had our dignitaries expand a lot on what we need to think through the rest of this week, the rest of these next 2 days. And I'd like you to come over and tell us what we're going to be doing next.
Let's give a round of applause to our moderator, all the way from Ghana, connecting. We're in the global world. I want to thank you, the speakers. And without further ado, ladies and gentlemen, I want to also take this opportunity. We are highly honored today. We have got our ambassador, Her Excellency Professor Charity Manyuruke. She just said, okay, let me join also this conference. Without further ado, please help me to welcome here Her Excellency Professor Charity Manyuruke. Just to stand, people you will see here, she's representing the President of Zimbabwe, and she just came to partner us also on this conference. Thank you so much, Her Excellency, for your gesture. Thank you. Now, on this, I just want now to invite on this plenary session. First, I want to invite Dr. Sabine Sansimana to come to the podium and take a seat. Please give a round of applause to our Rwanda Biomedical Director General. Then on second, I also want to call upon the representative of WHO to go also on the podium. Please give her a round of applause. She needs no introduction. She's part of the great team. Then we also want to call upon Dr. Duren Taka, the CEO founder and the founder, to the podium. Give him a round of applause, please. Then some of the speakers, they are going to be joining us also virtually. Then we also have, who else is there? If Dr. Joe Mubilingi is there, he can join us also on the podium. Please give him a round of applause. There is also Professor Wayne De Villas. I think they will be joining us live, I think virtually, shortly maybe on the screens. Then Dr. O.M. Prasad Gautam, I think they'll be joining us also online if they are not in the room. Then lastly, Sineka Samuel Siaban. Thank you. My tongue is almost twisted. Thank you so much. Let him join us also on stage. Yes. I just have an announcement. It's people who had this come in. Okay, you can announce it. You wrote it nice.
No, I didn't write it, but I can announce it. There's an announcement from the organizers that those who need their CPD points during the break, they should go and see Tadima and Joe at the reception for their registration. I think you understand that point. Okay, go ahead. Okay.
Thank you so much, moderator. Now, ladies and gentlemen, we are very honored today to call upon the moderator of this session, Dr. Jared Omolo. Can you please give him a round of applause as he takes his stage? Please, let's just do it loudly as he's coming on stage. Doctor, here. Yeah, or I'll give you the microphone. You can join them also on stage there.
Thank you so much, Walter. And thank you, our guests, for joining us and our panelists this morning. It's a great pleasure to join our distinguished guests and fellow participants to this year's Rwanda Global Healthcare Summit. As already mentioned, it's a really great opportunity to interact and exchange knowledge and enhance our awareness about emerging issues, ideas that allow us not only to tackle the current elephant that we have in the room, but also how to adopt the same as we continue to deal with our regular public health business. But of course, we do know that we will never go back to business as usual. The numbers themselves are 250 million cases, as reported by the Dr. Theopista, remind us that things are different. And so there's a signal to some paradigm shifts that we will have to embrace. This summit was postponed after several times, after 2 or 3 times, but we are here today. So it's also an indication that things are changing, but we do have an opportunity to just modify and shift the way we do things, and we'll keep going. The positivity rates in Rwanda, as reported by Dr. Sabin early today, I think we are at 0.2%, is a true reflection of what can be done, what the interventions and the concerted efforts of our people can help us to achieve, reduce the risk, and allow us to meet here today. And so, of course, it's not going to be easy, but we can keep pushing harder, smarter, and allow ourselves to pick ourselves and, like the proverbial phoenix, and make use of the lessons and opportunities to move ahead. And so we are going to have a panel discussion about global health funding, delivery, and innovation in this era of COVID-19. I think a number of the issues have already emerged during the opening comments, but we could hear a little more about how can we enhance efficiencies in financing, leverage on technology and innovation, and how do we really want to go further and faster together. So without much further ado, I think 4 of the guests have already given some opening comments, and so I'll invite the others who haven't Allow me to introduce, so Dr. Sabin, Dr. Theopista, Dr. Dhiren have already been introduced, so I'll introduce Dr. Joel Mobiliji, who is a physician and global health expert with extensive experience in healthcare delivery. He's a current executive director of Partners in Health, which is an international NGO that supports government of Rwanda in its efforts to strengthen healthcare. And then we have Dr. Samuel Sineka, the head of health systems integration in Zipline. Dr. Sineka is a pharmacist, a member of the Pharmaceutical Society of Ghana, is a current head of systems integration in Zipline, which is pushing to integrate the Zipline technology, the Zipline innovations with the health system in Rwanda, as well as building relationships with the public health stakeholders. So welcome the two additional panelists. So maybe I'll welcome Dr. Joel to give some opening comments.
Thank you very much, moderator, for this opportunity. I will apologize, I have a kind of a strange voice, but I think I will articulate well so that everything I say is listened. I think we have enough distance here, if I can I? Sure. So, my reflection really from the discussion that we had and also on the topic of global health, financing, delivery and innovation is I want to bring us back a bit in history and remind that the notion of health as a human right, as DG Sabin mentioned early, is not a new notion. It's not something that we have been reminded only in this pandemic period. That understanding and also commitment have been agreed, acclaimed, and signed close to 50 years ago. We all know the Alma Ata Declaration, but since then to now, we seem to not really finding the right formula and how do we do that? And when the HIV pandemic came, some of the people like Partners in Health and others who have been really involved into delivery of health services to the most vulnerable thought that, okay, this is going to be a game changer. HIV pandemic, the problem that is around will help people understanding that there's no two words, there's no global north and global south, or maybe even forward, east-west during the Cold War and so forth. So, I mean, there's an understanding that people, wherever they are, can be reached by a calamity, a disease, and other problems, and deserve to be treated, deserve to be taken care of. And we saw a lot of international engagement with that came through. But then we had to have again COVID happening since now close to 2 years to kind of remind us again that there is something that we are not doing well. And I wanted to highlight two things as a reflection to me that I think, we need to think about when you think about innovation. And what we have always been saying is that, humankind have not been short of ideas, have not been short of creativity. I think we have shown it, in many ways through multiple discoveries of medicine, technology. I mean, now we are sending tourists into space, and soon everyone will be able to have their own assorted virtual world, thanks to Mark Zuckerberg. So the technology, creativities, and the way people have been able to discover is there. But I think where we have failed is really to be creative and innovative in sharing that technology, in sharing the knowledge, in making sure that there is access to people who need it the most. When I may say need it the most, I'm really thinking now about health and the disparity that we have in terms of health outcome in the world. And keeping in mind, if I only take the African region, that has close to 17% of the global population. And that's where most of the poor health outcome is concentrated. So we failed really in terms of imagination and creativity to really make whatever modern medicine have brought to us accessible. And to me, I think the innovation, the thinking in terms of delivery, in terms of access, needs really to be reinforced on that level. What I would say is that, you know, if I want to use the terms in supply of medicine, you know, using or in appointment at the health facility, you know, we usually talk about a backlog of data, backlog of a patient waiting for, and I think we have also a backlog of technology, medicine, that have not yet reached the people that need it. So I think that's where Partners in Health, we have been really at the forefront, working with other countries and NGOs. In the HIV time, we were really pushing to show at least that, you know, antiretroviral medicine can be provided even in the most, you know, far and poor context. Because at that time there were even debate that you cannot actually even provide antiretroviral medicine there. Today we are doing it with cancer, where we can, you know, demonstrate that chemotherapy, however complex as a medicine can actually be provided safely in a context of a rural district hospital with general nurses and general practitioners. How do you do that? How do you demonstrate that? What are the technologies that you need to bring in place? What is the supply that you need to have in place? What is the protocols that you need to develop? That's the innovation part in terms of accessing and bringing delivery there. So in conclusion, I think places where I think when we think about global financing, we need to really touch the human ingenuity and bring innovation. I will talk about the global governance. Global governance, you know, we know major actors that have been influencing the way prioritization have been happening in the global health sphere, and also how finance have been oriented. You know, we have UN institutions like the WHO, we have international finance institutions, the World Bank, the IMF, we have philanthropic institutions and so forth. But I think we had an issue of authority. An issue of authority is like, how do we hold all of these influential institutions accountable into financing the right thing, you know? Even having the same goal. We had, the MDGs is probably among the first goals that we had to agree together, but that also had some gaps in terms of health system strengthening, in terms of social determinants of health. Now we have the SDGs, but who is going to be the authority to make sure that there is that orientation of funds and support to make it happen? The WHO has the legitimacy of expertise and the political legitimacy to do that, but we have seen historically even WHO being challenged. You know, the US, even in this pandemic, the US government had to pull out finances from WHO. In the Cold War, each country pull out and in, whatever it is. So that, I think, it's a big problem. How do we really create that accountable? The second, and I conclude, is enabling environment, regional and national. But we work in more than 11 country PIH, and I'm telling you the truth, no country is like Rwanda. The enabling environment that is here, the political will, the prioritization of health, the poor really being at the center, really gives, I would say, gives us wings in a way we can even be ambitious and tackle difficult things. So that enabling environment also is very important. Not saying also other things like peace and security, because each country in Africa and in our region have its own problems. So global governance, who's going to be the authority to make sure that that financing mechanism and goals of our SDGs really tackle issues of health system strengthening and social determinants of health and enabling environment at regional and national level are extremely important, and we need to be very innovative and tackle our human creativity to solve that. Thank you.
Thank you. Thank you so much, Dr. Joel, for the introductory comments. So, Samuel, do you have some initial comments on the work of Zipline and some of your experiences?
Yes, so it's really interesting to be part of this podium, looking at all the speakers. I think one of the intersections or one of the major things that is very interesting here is logistics and then supply chain. At the end of the day, you have all the products in country, but access becomes a problem. And that is where Zipline becomes very revolutionary and brings the game changing. So just to give a little context on what Zipline actually does, Zipline is a logistics company that leverages the technology of using drones to deliver healthcare commodities to health facilities. These are hospitals, health centers, health posts. That's what Zipline actually does. We are in close partnership with Dr. Sabin's entity. So Dr. Sabin is a very good friend, and then somebody we actually go to for a lot of insight. So RBC being an umbrella, we partner with them a lot. We work with the RMS, the Rwanda Medical Supply Limited, and then we work closely with BTD. We use these entities in distributing the commodities that they have in stock. These are mainly medical products and then blood units to all the health facilities that are within our catchment area. Currently in Rwanda, we have 2 distribution centers. And these 2 distribution centers, actually, we have a very good coverage. We cover about 90% of Rwanda. The little exceptions are where we are not supposed to fly through, and these are no-fly zones that are being earmarked by the RCA for obvious reasons because of the commercial flight. But then the point I'm trying to draw is access to healthcare. Dr. Sabin, in his speech, made mention of the fact that access to quality healthcare is not a privilege, it's a right. And we as a company are making sure that we are leveraging that technology to make sure that each and every person, no matter where you are, gets that quality healthcare. You get that quality product that is supposed to enhance your health status. So right now, I think COVID has come. Everybody has been forced to come into terms on unilateral and multilateral partnerships in bringing global health is now the talk of the day. The question now is, how do we do the implementation? We've seen Additives is talking about manufacturing, and these are entities that Zipline is looking out for in partnerships. You could just hear Dr. Joel also talk about how they are being innovative actually in delivering cancer medicines. And this, we've been in very close partnership with Dr. Joel's outreach, Partners in Health, in making sure that people during the restrictions where they couldn't move from one district to another, even in the comfort of their vicinity in the districts, they were able to get access to their chemotherapy. And this was possible because we partnered and were able to deliver most of this chemotherapy to the district health centers where they could equally get the quality health care that they needed. So as a right, we are not supposed to deny anybody who is sick quality treatment, and that is what Zipline actually stands for, using our revolutionary drones in delivering health commodities to all that are in need of healthcare. So basically, that is what Zipline does, and that is what I just want to talk about for now.
Thank you so much, Samuel, for highlighting that. So before we go on to the questions and answers, there are also two people who are joining us online, virtually. So we have Dr. Om Prasad Gautam, the public health expert on behavior change, scientist with more than 21 years of work and research in WASH, water, sanitation, and hygiene. So Dr. Om, if you are following, if you could kindly provide some brief comments on your work and how it fits into this theme about the global health funding, innovations, and delivery of care. And then we'll have the video from Professor Vin de Villiers, the Vice Chancellor for University of Stellenbosch, and then we'll go on and start the questions.
Thank you. Thank you very much. Hopefully you can hear me okay. Can you hear me okay?
Yes, we can hear you. Please go on.
Yeah, thank you. Great. Very pleased to be here today. I have prepared some slide, if that's okay to present. Do we have the slide there, or do I need to share my screen?
You can go on and share, it's all right.
Sure. Let me share the screen, and I will present. Hopefully you can hear me now, and then you can see the slide. Very great to be here presenting on behalf of WaterWed, and thanks for the introduction. So my few-minute presentation will be making the case for hygiene, how important hygiene behavior change is to prevent the current and future pandemic. As a human being, we all know that we need to be healthy. We need to be strong. But the poor hygiene making people sick, keeping children out of school, stopping adults from working, putting mothers and babies at risk, and also putting our health institution in schools as source of infection. Hygiene matters in every setting, as it was evident throughout the pandemic that households, schools, healthcare settings, workplace, public places, and policies. And due to lack of behavior change, we have seen lots of preventable disease still prevalent. As we talk, in every 2 minutes, a single child dying from diarrhea, which is equivalent to 2 jumbo jet planes crashing every day. And in the COVID era, we are still facing these challenges. And WHO urges that we need to have the more holistic approach to prevent, treat, and protect. But unfortunately, in many cases, we're focusing either on treatment or protection. How much are we doing for the prevention is one of the key. Despite knowing the fact that a simple measure of hand washing can reduce the diarrhea by 48% and can reduce the seasonal coronavirus, the flu-like illness, by 36%. It can also prevent the hospital-acquired infection and can reduce and prevent other pandemic and control the outbreaks and pandemic. It has been proven as a cost-effective public health intervention. Making hygiene part of the development program will reduce the disease burden and also reach many development goals. But the problem is only few countries has costed hygiene plan. 2020 Global Glass report tells that only 9% of the countries who has the plan has enough budget to implement it. But with the new initiative of hand hygiene fall initiatives, the 41 countries now in process of developing the costed plan, but it will cost around 13.7 billion US dollar over a period of 10 years. Though this is a cost-effective public health intervention, it is not costly. So hygiene, we need to focus on this. And as we talk today, 30% households still lack hand washing with soap, and then around 43% healthcare facility do not have a hand washing facility and soap to treat our clients. If the same progress goes, 1.9 billion people will be still out of hand washing facilities by 2030, which is when we wanted to really achieve the SDGs. We are lacking behind. Why this is not happening? Colleagues in the sector, many organizations still invest lots of money on educating people, threatening people using health and germ-related messages, poster leaflets, those are not educated enough to change the people's behavior. There are limited intervention who actually works on using people emotions, disturbing settings with cues and nudges, having social marketing approach only change the people's behavior. So it is time for all of us to think what works and what doesn't, and really use the things that actually works, and moving just beyond the infrastructure and knowledge focused intervention, focus on behavior change, motivate people, create social desire, social norms, focusing on people motivation insight is quite key. So therefore, it is also into the sector, what we in particular, we use evidence-based behavior-centered design approach to design, implement, and evaluate our hygiene behavior change program. Our intervention basically informs based on the formative research, designing an intervention that will motivate people, and delivering with a multiple prong approach with thorough delivery mechanism with emotions is quite key. And also, we need to evaluate the intervention so that we can demonstrate the effect. Using that model, currently, we are implementing 17 different international, 17 different campaigns in different countries, including majority of them in African settings, hygiene behavior change campaign. And throughout the pandemic, we have actually leveraged these campaigns in order to respond this. We have responded COVID-19 in 26 countries, targeting 99 million population, focusing on multiple behaviors, including hand washing with soap. And we're moving beyond fearing people. We're using people's emotion like affiliation, nurture, pride, status in order to change the behavior of the people. And we really design an intervention based on evidence and have a creative process to design the intervention package. And we have achieved throughout the pandemic, we have achieved 181 million people. We have reached them through mass media, digital and social media campaign, and through community-based campaign. We have also installed 2,700 public hand washing facilities in different locations. We have put visual cues, nudges, and reminder. For behavior change, just not telling is going to be enough. So we need to build the facilities. We need to make sure that products are available with the visual reminders and reinforcement in key locations, including motivating people with the emotions. And we have also distributed products, 1.8 million hygiene products, and products need to be there for those needed. What I'd like to do, I'd like to show you one video that will demonstrate how we have implemented it. If you are seeing my screen, and then I'll come up with the key points that we have learned. by just looking this, you can already imagine that how intensive the intervention design was and also implemented. And it was important for us to move away from more education to more emotional and making it trusted. And throughout the pandemic, there was misinformation flooded into the mass media, digital media, and so forth. So it was evident for us to work with the government, national government, to design and implement behavior change campaigns that are trusted, reaching to the marginalized people, excluded people, and also the intervening in the community to expose people multiple times, and also integrating hygiene into the vaccination campaign. Colleagues, my humble request, this is a health summit, and we know that, colleagues, there are advantages of the vaccines, the COVID vaccines. It's going to save significant life. But at the same time, none of these vaccines are 100% efficacious. But at the same time, the people who got the vaccines still can transmit the disease. So it is therefore important that we still reinforce hygiene behavior change through this vaccination campaign. So we have also demonstrated work with few countries, particularly in South Africa and Nepal, and currently working with the Mozambique government as well, to include hygiene into vaccination campaign. It is important that I think in Rwanda and other colleagues in African settings, we don't miss this opportunity. Finally, and then also placing hand washing facilities in public places is quite important, and making them sustainable over time with the operation and maintenance plan in place is quite important. Water has done this significantly, and results has demonstrated, our midterm rapid assessment has also demonstrated significant results in terms of whether people are aware about this behavior and whether these interventions created a social desire and norms. But what we have learned when we promote it, there are subset of the behavior that we need to be very careful to look into it. Finally, my 5 key points to conclude. 1, we need to care about science. When you respond pandemic, the targeted behavior needs to be disease sensitive. It has to be rapidly applied. So we need to look creative ideas and making hygiene behavior change more attractive and emotional to the people. We need to have a higher exposure. You know, throwing messaging 1 time, 2 times is not going to work. So therefore, making mass media campaign trusted, important. It is important that we avoid creating a fatigue to the campaign. People are already fatigued looking the same message again and again. So therefore, making progressive content and making sure that people have their target audience and diversity into the content is quite important. For hand washing with soap, contracting takes time. There are lots of innovation. We have done installed food operated, paddle operated, hands-free hand washing facilities in multiple countries, but operating them on a daily basis with cues and nudges and reminders is quite important as well. At the same time, we need to focus on the coordination, the inclusivity, the sustainability and financing. The government leadership is quite critical, and those functional coordination mechanisms are identical. And we need to be intentional to address the equity and inclusion issue. There are people excluded throughout the pandemic. And we need to make sure that the promotion of the hygiene behavior change intervention campaign, the placement of behavioral products with cues and nudges, and the costed plans need to be together in one pack rather than implementing in silo. I will urge to conclude that we need to think big and act big. We need to implement at a scale. We need to integrate hygiene into multiple implementation touch points, including health, education, nutrition, and majority maybe within health, maybe from the immunization programs and other. We need to politicalize hygiene. It is important that we retain this political attention in coming years. We are still dealing with the COVID, but we need to still continue that. Donor behavior need to be influenced in order to have the educated financing in place. Evidence-based campaign need to be there, and public-private partnership need to be strengthened, and there lots of innovation need to be bring in place, and that is possible. I think throughout the pandemic we have seen that that is possible to bring that partnership on board, to have a costed and long-lasting plan in place. With that note, just wanted to flag those points, part of these keynotes. Thank you. Over to you back, Chair.
So we do have another presentation, but maybe we can start off with the panelists who are here. A few questions. And Dr. Saben, if you allow, I'll start off with you. So you shared some very good lessons that have been learned in the response to COVID-19 in Rwanda. Mentioned leadership, partnership, science and data, innovation. And I think it's clear from the current risk assessments and the incidents in Rwanda that a lot has gone well when you look at the maps of the world in the different countries. So can you tell us, how did it all come together? How did we achieve this almost perfect synchrony that seems to have been a challenge in different settings? We've had the challenges and the distrust of science and hesitation to embrace new ideas, innovation, but it seems to have proceeded on, to have evolved very well in the Rwandan setting. If you can share a little more. And this, what has worked well, how do we integrate these thoughts as we move forward with health service delivery, even in other aspects of our healthcare system?
I think this is better. So thank you, Dr. Gerard. That's a very complex question, because I think COVID was probably the biggest challenge for public health experts across the world, but also for anyone who was playing a role in the response. And today, I can't even say that we are over it, or is any perfect experience to be replicated or exported somewhere else. But maybe a few reflections on what we've seen. Some already mentioned during my previous talk. To me, it was like raising a child or a kid. Sometimes you don't know how the next day he or she will look like. You just do what you need to do at that particular moment. If it's providing proper nutrition or proper care, or being sometimes setting rules, go to bed or wake up, that has been a process, and you couldn't tell what will happen next day until you go to next day. But at the same time, we were running as we move, and probably the most important thing has been adapting to the situation and be as creative as possible to what was the challenge, not be held or contained by the challenges, but rather taking it as an opportunity to think even wider where the responses or solutions are. Of course, for our case, we were lucky to have so many people working around the same issue. Different sectors. You'd have the local government here, education sector, the commerce industry, tourism groups, all speaking almost the same language, although they were being affected differently. And that is part of what I said earlier before, that leadership that can bring all those people around the table in a regular way and without any conflict of interest whatsoever, other than this is the data, what do we do about it? That has helped, and that's why I was saying evidence and data, when you believe that it can help, when there's nothing behind pushing you, oh, let's not take this measure because it will affect my sector or my economy or my activity. That truly has been the key particular thing I've observed, being somehow in the, I would say, in the center of so many actors, but having also the leadership on top that was very supportive, saying COVID is there, just apply what the science is telling you to do. So that is the few things I can say. I hope that COVID will end sometime so we can tell the true, the long or complete story of what we are going through. But so far so good. We have better tools, we have tests, we have vaccines, we have non-pharmaceutical interventions that are very helpful, and we have more and more partners who are willing and even coming here. Some are here in the room, and even the panel that have already made very good comments on this partnership. So let's keep learning, and the thing is believe in data and science and invest into that. Then what comes from the evidence you have, use it in real time.
Thank you so much, Dr. Sabin. I think the theme keeps recurring about the leadership and harnessing the resources and the partnerships in the country and putting it all together to adjust as we learn the lesson. So thank you very much, and we keep hoping, of course, that the same will continue, the numbers will stay low, and we'll keep telling the story as we continue. So, Dr. Theophister, our next question. I think the other thing that keeps coming up a lot, and we, of course, are recognizing, and it keeps being echoed across in different conversations about COVID revealing some of the issues we have needed to be aware of in global health. Some have been hiding in plain sight, and we mentioned equity, collaboration, accountability, and so on. So from the WHO perspective, what's your sense? Have we learned enough? Do these words have new meaning? And have we learned enough to change, applying this as we move forward in global health? If you can share some perspectives or reflections on that.
Yes, thank you. As you rightly said, that we have key words of which we have been hearing or in the past, and even more now with the COVID. From WHO perspective, on the issue of equity, using the data, it is COVID has exposed the world that there is huge inequity between the continents, between the haves and the have-not, and when even you go down to the national level in the communities, some communities are more privileged and they are more vulnerable, but you need to have this data in order to be able to see where the inequities are. Citing the example of the access to vaccine and the other tools for responding to COVID. We have seen that most developing countries, they are experiencing more inequities in accessing the vaccines. And even when you go down at the countries in which they access the vaccine, the use and uptake of the vaccine still is a challenge. So, and we really needed to globally look at these inequities and put in place measures to ensure that we address all these inequities to ensure that everybody access the tools and the vaccines which are available to combat COVID. And as the WHO Director General says, no one is safe until everybody is safe. So we really need to address that. On the issue of collaboration, I could not agree more what Dr. Sabe is saying about partnerships, multi-sectoral response, all government response from all the sectors. We really needed to ensure that the way we've been looking at the collaboration and partnership, we needed to change the way we've been doing it so that we can be able to address the pandemic, and where it has been implemented well. For example, for the case of Rwanda, you could see the progress which has been made in addressing the pandemic. And where the partnerships and the collaboration is lagging behind, you could see that there have been difficulties in addressing the pandemic. On the issue of accountability, for the case of COVID and even the other public health issues, it has to start from within, from the individual, and then collectively. And we also needed to have the government, good governance, which puts emphasis on this accountability. And we also need to honor the commitments which we make in addressing being COVID and even the other health emergencies. For example, the area of maternal, newborn, and child health, we have been seeing the high levels of maternal mortality, high levels of newborn mortality, child mortality. All this need to be, we need to be accountable so that we can be able to reduce all these deaths from preventable causes. And therefore, from the individual level, from the government level, from partners, we all need to be accountable on what we are doing in order to make a change. Thank you.
Thank you, Dr. So it starts with us, the accountability, but goes all the way to the government levels and the global players. Now, you mentioned also some of the inequities in access to medicines, and of course, we have had this, we all are aware about the challenges of the vaccine, especially in the developing countries. I think Dr. Sabin, of course, mentioned this. There was resources, but we can't get them, the vaccines. And it's a good segue to Dr. Thacker, if you can please elaborate more about the Med Adidas. Why sub-Saharan Africa, and what medicines are you looking to produce, and what challenges do you anticipate? Sorry, sort of three questions in one. Which medicines, why Africa, and what are some of the challenges you?
So I think I touched on why sub-Saharan Africa. Clearly, as I'm looking at access to medicine, there are many countries where the problem exists. But certainly in this region, the problem is more acute than many of the other regions that certainly we have studied. Just imagine, large percentages of the population have practically no access to medicine. The problem of falsified and substandard medicine by WHO's studies shows that one of the highest rate of these type of substitutions are occurring in this region. So on one hand, there are challenges or there are problems. On the other hand, there are opportunities. I think as you mentioned, this is an area that is economically developing. The standard of living for other people is going up. So when you have need and when there is an opportunity to actually meet the need and at the same time private sector can actually flourish, when you have that combination, that is the place that I feel that we can make biggest impact. And it is all about, not just making an effort, but it is about ultimately producing results. And I believe that this region is ripe for intervention, ripe for promoting this whole notion of we have to do this by creating local capacity. So there are many reasons why after looking at this problem worldwide, I felt like I need to come here. And then, of course, I'm coming here with no illusion that there are challenges, and you asked me about challenges. Some of the challenges have existed for quite some time, and I hope that there is a changing landscape. Access to capital is a big problem. We can bring capital from outside, US, Europe, and all. But I think most of the investors are going to look for de-risking their investment. And so unless we have some investment coming from the country where we want to really set up the enterprise, it is hard to bring that convince the investors to really put the money. So that's one. There is clearly need for improvement in infrastructure. While I was here in Rwanda 3 months ago, and I also visited Kenya, I was looking at some of the basic needs to really set up a pharmaceutical manufacturing. A continuous, dependable supply of electricity, clean water, ability to be able to dispose of our, whatever comes out of the industrial processes in a way that is responsible, in a way that such that what we put back into environment is at least as good or better than what we take in. So these infrastructure issues are definitely a challenge. Not that we cannot surmount them, overcome them, but there are challenges. Perhaps the most important challenge is access to locally trained individuals who can participate in manufacturing operations. This is a big problem, and in fact, because we can bring talents from outside, but you cannot sustain such an enterprise entirely on talents that come from outside of this region. In fact, we are so convinced that the local talent is critical that in our sort of long-term plan, besides setting up manufacturing, we also want to actually put together targeted workforce training programs in collaboration with local as well as international universities, and certainly we would like the government to be our partners in this. So we do have challenges, but I think we can really definitely meet them head on. Lastly, what type of medicines? I think we have done a lot of research, and I think our goal is to really focus on unmet need. At the same time, we have to be economically and financially viable. So we have tried to really select drugs, classes of drugs, which allow us to do both. 3 areas where we are going to focus on. 1, pediatric drugs, drugs for children. This is a real awakening when I did research. For the continent where I think 40+% of the population is under the age of 18, there are very few medicines that are specifically developed or imported for children. Too often, adult drugs, adult formulations, are given to children in some sort of a makeshift way. This is no way to treat children. So we want to become a company that is known for pediatric medicine. Secondly, we want to focus on, this was already has come up this morning, non-communicable diseases. We have, obviously there has been a historic focus on infectious diseases in this area, and that was justified. But as economic conditions have improved and as the middle class has grown, the lifestyle diseases, cardiovascular, diabetes, some of the cancer are growing, and there is a growing need to address this. So we are going to focus on medicines for non-communicable diseases. And finally, I think this was also brought up. We call them neglected or forgotten tropical diseases. This is an area where I have a special sort of passion. There are particularly diseases that are caused by parasitic infections that they afflict children, and it creates sort of a long-lasting sort of problems and impact on a life of these children as they grow up. And the solution to these diseases have been addressed typically in the past by donor programs. So international organizations have, of course, focused on this. They have developed medicines for this. They have then found ways to manufacture it through contract research or asking pharmaceutical companies to really make it and donate it. I believe the time for relying on donor program is over. I think it is time for us in this region to not only develop medicines that are necessary to fight these diseases, but we need to really build capacity to manufacture them. We cannot rely on donation forever. So these are some of the areas that we want to focus on. And of course, as we go forward, we would like to really expand R&D operations so that we can focus on local diseases and local solutions. Thank you for listening.
Thank you so much, Dr. Viren, for those very clear reflections and plans on the company, Med Adidas. Now, moving to Dr. Joel, you had earlier mentioned about the role of partners in health in providing healthcare and building systems, especially in resource-limited settings. And we do know COVID has impacted everyone. There's been pain and shock in all strata of the society. And you are on one end, and I'm just curious about if you can share, how have you stepped up to mitigate some of these challenges among the communities where you work, and what are some of the innovations that you have embraced or scaled up since the COVID-19 started in areas where you are?
Thank you very much for that good question. As we say, the COVID-19 pandemic really have shaken not only the world, in countries, communities, and everywhere where we have been working, but again, it has proven even more the importance of a strong health system. And I think among the other things that Dr. Sabe mentioned in terms of the leadership, the partnership, the coordination, I think nothing would have contributed more than already the effort that the country has been making in building up a strong health system. And that has been something that we build on as well as we are designing our interventions as partners in health. As I mentioned, our effort in innovation have been focused really into the delivery process. How do you get knowledge, expertise, technology serve the people who need it the most? And how do you bridge that gap? Some challenges have been said by a previous speaker in terms of local capacity. And the question have been, how can we be innovative in building that local capacity? What do we need? What are the level of skills that can be transferred to which capacity? Which supervision do you need to have in place? What information system you need to have in place? Let me take an example using the information system. We have been designing that delivery of service, especially around diseases related to oncology, NCD, mental health, and others. And with the COVID-19 pandemic, we know that the people who are the highest at risk are people with non-communicable diseases. So when this is happening, we sat and were like, okay, we have close to 7,000 patients that we serve with this service at rural places. What is happening about them? But a good thing is we had data in hand. So we knew which patient has which disease, they are in which, on which drug, where do they live. Those are the things that helped us actually to work. I mean, when we reached out to Zipline, just take an example, the conversation was like this. Say, listen, we have the drugs. We know which patient needs the next drugs, the next doses, and we know where they live. You have a medium on getting to them. Can we work together? And then that partnership was built. I remember having that call on one day. It was, I think, probably like a Tuesday, and by Thursday, the first delivery started of our patient using drones and so forth. We had to work with RBC and other partners to develop a logistics system in bringing, and that was for patients who use oral chemotherapy. And we had to work with RBC and other partners to find a way, a logistics system to be able to transport and move patients who need intravenous chemotherapy and mobilize cars around them. And I think the thing there is really an attitude in that partnership that is, first of all, very generous, and also an attitude in that partnership that is, not locked within a certain way of working, willing to really focus on the how can I put it, to really focus on the human tragedy that is going on that place around those patients, and go the extra mile and help really that patient. So that really allowed us to be innovative in the way we tackle those issues. When vaccination campaign started, we knew where our NCD patients are, and we had their phone contact. It was easy to work with the local government where vaccination services is happening to make sure that these patients are prioritized in getting their vaccines and so forth. So all of these things really shows you the importance, when I mentioned earlier in my introduction, of really being, having a real lot of imagination on how we close that gap of delivery and building and building the system. And that said, I think we also need to be realistic in terms of how much that costs. We always talk about cost effectiveness, and my previous speaker talked about capital and so forth. But the reality is the region where we are in Africa holds less than 3% of the global GDP. So when we're talking about that, the reality is it's very difficult to actually produce that capital. And it's very difficult to actually be able to really reach a cost effectiveness that really puts, again, the human dignity where it has to be. Recommendations for access, universal health access, ask for public fund allocation of close to $86 per capita. But that recommendation is for who? Where we know that some countries, like in Scandinavian countries, they spend close to $2,000 per capita. Other countries, like in Dubai, they're close to $4,000 per capita. So the $86 is for who? Will the $86 allow us to produce locally? Will the $86 allow us to tackle diseases like cancer? Will that allow us to tackle issues like orthopedic surgery and things like that? So I think that's where, I think we need to really, first of all, put our ambitions a little bit higher than that, because, early in the introduction, Dr. Saben talked about cheap health systems. Not really aiming for cheap health system, but really a health system that can be robust enough to tackle pandemic like COVID and other diseases like cancer and others. So I think that's what we have been able to do in terms of partnership, collaboration, but also putting there a core challenge to be a little bit more ambitious in what we think in terms of a health system from the lessons that we had with the COVID-19 pandemic. Thank you.
Thank you so much, Joel. And now, lastly to Samuel, if you can share some thoughts, and as we, sorry, we are running over time, but we're beginning to close. Sorry, we started a little late, and conversations are really interesting. I don't know how you're finding it. I was almost getting carried away and forgetting the time, but we do have to be realistic about the time also. So we'll be beginning to close the next 10 minutes or so. So Samuel, maybe if you can provide some additional reflections on the opportunities that exist to expand the use of the technology that you use to improve aspects of service delivery.
Thank you very much for the question. So there are a lot of opportunities that with this pandemic, we realized that zipline drones could do. We realized the kind of transformation we could bring into the healthcare space. So traditionally, we would usually just deliver medical products and then blood products. But with the onset of COVID-19, we saw that there is innovation in innovation. Zipline is an innovation, but we also saw that internally we could become very innovative to be able to adequately bring up our systems to deliver the COVID vaccine. In Ghana, for instance, Zipline has delivered about 250,000 doses of the COVID vaccine already. Just last week, they delivered the Pfizer COVID vaccine, which actually is the most sensitive one. So there is that opportunity where we can leverage the drone systems to deliver or help in the vaccine delivery, for instance. We've had instances where even childhood immunization vaccines have also been delivered. I think around 1.7 million doses has also been delivered in Ghana. There have been those opportunities where we've used Zipline to deliver COVID samples. This increased the turnover time where patients usually would all, and people usually get their test results within 24 hours because of usually the transportation was one of the major challenges. So Zipline has to step up to be able to do the delivery of these biohazards, which greatly increased the testing periods and then the quantity of people that were also being tested. In Rwanda, we've seen that there's a lot of opportunities that we can also leverage. One is also actually Zipline is revolutionary and started in Rwanda. This is so visionary of the president who started this in way back in 2016. And I think any other country that is in the world right now, we are currently in Ghana, we are in Nigeria, in 2 states in Nigeria, we are currently in Cote d'Ivoire, we are setting up, and then we are moving to so many other African countries. And I give all the credit to the proof of concept that was actually done in Rwanda. And then I think that there's a little more opportunities where we can still use this logistics transformation of using drones in the healthcare space by also delivering most of these vaccines. We have been doing some partnership actually with RAP, and then we've been doing a partnership of delivering some products for RAP. We've done a lot of case studies with them, looking at how to implement it, and therefore going into the agriculture space and all that. So yes, Zipline, there are a lot of opportunities that we could explore looking at the deliveries, but then we are also looking at partnerships. Right now, you look at the donor environment, usually concentrates on the traditional way of putting a lot of funds into the traditional ground deliveries of logistics, and then to the neglect of the drone tech companies. And this is actually a little discouraging to us. So we are also looking at the fact that if the donor companies can also extend their tentacles into the drone companies and then supporting, so that we look at how revolutionary supply chain is going to be. That would be actually the way to go in this trending world where COVID is there and we do not know which pandemic is next.
Thank you, Samuel. Dr. If you're still there, you mentioned, and I think we've also recognized the central role of hygiene, WASH, in the COVID response. If you can give us some reflections on what you've learned on behavior change as far as hygiene is concerned, and how are we going to move forward with the behavior, the WASH initiatives and WASH initiatives and behavior change, rather behavior change and WASH. I think it's really been a tough area even in the past in most of our settings. So what have we learned and what are we doing differently? What are we going to do differently? If you can provide some summative reflections on that as we come to the end of this discussion.
Sure, absolutely fine. Very critical question. How do we actually sustain behavior over time, despite we're failing to do that in a normal development scenarios? And during emergency, it has been even evident that these sudden change in behavior due to fear of COVID or any other pandemic. We know that fear is always going to be a temporary stimulus in changing the people's behavior for a certain time frame. When fear goes, behavior also disappear as well. We have seen that has been evident in Ebola crisis, cholera outbreak, diarrhea outbreaks, and now in COVID as well. So sustaining behavior over time has been one of the fundamental critical determinants of behavior change program in many countries. What I have learned and what we have learned from WaterAid through our operation in 26 countries from hygiene response to COVID-19, that we need to have the right institutional mechanism to deliver these change behavior. The behavior need to be reinforced over and over. Previous speaker has mentioned about the capacity. We need to build the capacity in the right institutions so that those built capacity is going to constantly reinforce the behavior over time. So that is one of the fundamental key. How do we actually ensure there is a mechanism of reinforcement of behavior over time, but not only telling people about changing their behavior, about making those evidence more evidence-based and emotional. Making trusted campaign is quite important as well. So therefore, throughout the pandemic, as you can see that some of the initiatives that we have done has shifted from knowledge-focused intervention to more on emotional and trusted campaign. How do we make it? Basically use trusted target populations, trusted character into your promotional campaign, maybe celebrities, comedian, athletics, and deliver through the right government institutions so that those institutions are there always to reinforce the behavior. That is one. Second, in order to sustain the behavior, the behavioral products and the behavioral facilities need to be there. We are still struggling that around 40% healthcare facilities and schools and around 30% households do not have hand washing facilities. I think throughout the pandemic, it was evident that there are lots of innovation happens at local level from local business companies, different partners in order to make these facilities available, even in the public places, market, bus stands, transit in border areas where there are high mobility of the people. Things possible, even in the emergencies. But these has to be sustained over time. The operation and maintenance plan has to be in place. And these facilities need to be functional over time. So that means there should be a mechanism of retaining these facilities, building these hand washing facilities, in ensuring that in households, in public places, and in institutions are in place. So we need to make sure that there is a right investment into the sector to ensure these facilities are built and maintained over time. Third component, I would say integration is important in order to sustain the behavior. You can deliver in parallel, you can deliver things in silos. but that's not going to be sustained over time. If we build through the existing programming, through water sanitation and hygiene program, integrating behavior change component, through immunization of child health or maternal health or nutrition programming, so that these things are delivered within the right institutional mechanism and behaviors are reinforced again and again through an integrated programming, it's quite vital and that will sustain. Final point would be, is not only changing people's behavior in the ground. We need to have the right environment, and that environment will only come if we have the right strategic plan, national plan, which is costed and financed over time. So there is an initiative going on in many countries at the moment to develop hand hygiene for all roadmaps, and it's costing. It is important that we, all actors, including government, actually develop these plans and finance over time in order to sustain this behavior. I think I'll stop here for the sake of time. I will stop here. Over to you, Chair. Thanks.
Thank you, Dr. Oman. We can continue the conversation the next 2 days, but we'll still be here. So thank you so much. And I don't know, Dr. Sabin, if you have any closing thoughts, 30 seconds. Are you optimistic? Are we?
Always. I look forward to the capacity that all the brains in this room and outside can do to do things even better. On the issue of partnerships and how we could frame it better, I want just to make maybe one comment as we close this session, that the way funding to build health systems has been coming and managed in the past was not perfect. Why I'm saying this is, if you count the dollars, the amount of money that came into different programs, let's take examples of diseases that we all know well. The 3D, TB, malaria, HIV, and others. You can have, let's say, 3 examples. Examples where the money has come not just to target a virus or a program, but the system. Because someone may have different type of viruses. So you can't go and search one virus in someone's body. So that was the best example, but unfortunately, it's not that has been supported and taken as a gold standard for funding systems in countries. So if we have to take one thing forward, I think we should see how we fund programs, systems, health systems to deal with diseases, not funding diseases-specific vertical programs. On the other side, what didn't work is earmarked money going to not only just a disease or a program, even activity that can't change unless you have 6 months meetings, negotiations, and workshops to change one line activity from a workshop to buying test kits, for example. So if we can't create flexibility around that, we will even have more challenges if another virus is waiting us in the future. Thank you.
Thank you, Dr. Saben. Dr. Kabuteni, any closing remarks for 30 seconds, if you want to reflect?
Okay. Yeah, let me try. I think what I can emphasize is the issue of governance. We really need to have better governance so that we are able to have a well-coordinated and response and addressing even the other issues related to the health systems. Secondly, is building a resilient health systems, and we really need to invest in that. And the COVID has shown us that we really need stronger health systems which are resilient and be able to detect, prevent, respond, and at the same time ensure continuity of essential services. On the financing, globally and national governments, we need to build sustainable health financing mechanisms to ensure that we protect the vulnerable people and ensure no one is left behind. And we need also to ensure that health is not a luxury, it's a human rights issue. It's not a cost, it's an investment which we really need to deliberately do. And it is not an outcome of development, rather it is a foundation for social, economic, political stability and security. Thank you.
Well, thank you. Very thought-provoking. It's not an outcome, it's a foundation. Dr. Duran, some quick closing remarks in a minute or less.
Well, since I'm going to have an opportunity to talk again tomorrow, I'm just going to, in the interest of time, pass at this point, except to just thank the organizers for getting us together, and also commend the country of Rwanda for putting healthcare at such a high level of priority. Thank you.
Thank you. Joel.
Thank you very much. I think I will conclude with what I started with, saying that we still have a huge backlog of technology, medicine, knowledge that have not yet accessed the people who needs it. So I think financing mechanisms, delivery mechanisms need to really be reimagined to make sure that those, we clear up that backlog and actually prepare for the future of other innovations that comes in. That's the first point. The second is the issue of global financing and what authority do we put there to make sure that all the financing mechanisms, being national, regional, global, really focus on what Dr. Sabe mentioned on health system. And here we are not saying about cheap health system, there was a time where the major investment was focusing on, diarrhea, family planning and others, but we saw now, which are still important, but we saw with the COVID, the needs to actually have enough oxygen supply, the needs to actually have a certain level of intensive care services, which we did not imagine, but now is becoming a priority and even a plan for people to really execute. So can we look even further than that and think about other issues that are not yet tackled, that need to be prepared to make sure that the system is ready for the next pandemic or anything else that comes in the future. I talked about the delivery of services like NCD, cancer, mental health, and so forth. The Rwanda government did a lot of work in increasing the public funds allocation from something close to $8 in the aftermath of the genocide to close to $40 per capita. This is the last HRTT, which is already huge progress. But that still is not able to cover, chemotherapy for the most vulnerable someone in a village somewhere. So I think that ambition, I talked about the $86 recommendation for universal health coverage. I think we need to raise our ambition even higher than that and providing support according to the context, where Rwanda is, where another country is, and so forth, and allowing the flexibility within that country to really tackle a robust health system. Thank you.
Thank you. Samuel, you have the last word.
Thank you. So, like the rep from WHO mentioned, we have had different variants that have come, and then they are forming a team and attacking us. So this is the time for us to also come into partnerships. We form teams and then deal with them. This has been a very big lesson to the whole world and then a big blow. This is the time for us to form partnerships, teams, and then prepare for whatever that will be coming. We have learned a lot of lessons, and then we do not want to be in a position where there is a pandemic before we start to prepare. But we have the systems. what we need, I believe, is to strengthen the systems, to form partnerships, to form teams. And I like the fact that Dr. Sabin mentioned that sometimes you just need some meetings to buy nose mask, and then it will have to take you like 6 months before, so, okay, now you have the grant. So the other thing is, how do we scale with this multinational and donors to make sure that some of these processes are so seamless and fast so that it will enable us to tackle the pending issues as soon as possible. So these are just the few thoughts that I have for all of us to go through. Thank you.
Thank you so much, and thank you the panelists and the participants. Thank you so much for your patience and for being generous with a little more of the time before the break. So many things to say, but very clear. There's clarity of thought on what we need to prioritize. I'm not going to attempt to summarize for the sake of time, but we are hearing systems, evidence, opportunities, initiatives, being realistic, and partnerships. There's an East African saying that says, if you want to go fast, you go alone. But if you want to go far, you need to move with people. You need to go together with people. And I think initially we did think that COVID was going to flash off fast, that the faster people would take care of it and move on. But I think the reality is that it's going to be a long, long journey. And we will have to move together. And that's why the partnerships keep coming up. And it's not a choice that we have to make. It's inevitable. And so these keep coming up again and again, and we want to appreciate our panelists for helping us reflect some more on that. And yeah, please join me in a round of applause for our panelists. Okay, thank you.
Ladies and gentlemen, another round of applause for our distinguished panelists. Thank you all very much. And applause for yourselves as well for being such a wonderful audience. We do apologize for the delay, but there is a breakfast, snack, refreshments outdoors, outside the main entrance. Instead of 30 minutes, we really crave your indulgence.
It's going to be covered many topics. I think this is the master key and draw card of the conference. To those at the door, to those on the entrance, ushers, please help me. We want to have one conference. Ushers, please, can you help me to those at the aisle or on the entrance so that we have one conference, one summit. Please, can I have ushers, please, it's time to get the house into order. To those at the door, please, can you cooperate a little bit? Then it's either you're inside this auditorium or you're on the exhibition stand. Ushers, please, can you help me there? So that we don't have much feedback of the noise on the entrance. Ladies and gentlemen, I want to thank you for coming to this session, which is prior to our lunch, and we have already consumed much more time to this so that we might compensate it and squeeze it. Time is very important, especially on this session. Ladies and gentlemen, without further ado, let me just call upon our moderator, Dr. Kalope, all the way from Kishukai Medical Corporation in Japan. Ladies and gentlemen, help me to welcome our moderator of the day. Can we give him a round of applause? I think we can do better. This man has flew all the way from Japan. We can do better than that. Thank you. Thank you so much, Doctor.
Good morning, ladies and gentlemen, or good afternoon. I'm really pleased to be with you today, and we are going to have an interesting session. And the session of today, or in this room, will be around universal health coverage. And when we talk about universal health coverage, something just comes in our mind quickly. This is like leave no one behind. As announced, my name is Akintije Simba Kariope. I'm a medical doctor and researcher, biomedical sciences and global health, tropical medicine. I've graduated from Nagasaki University with my PhD 2 years ago. And now I'm working in Japan in a medical corporation called Kishokai. And maybe those who will attend the session in the afternoon will hear more about Kishokai. I'm really happy to be with you and moderate this session. And I think we will have an interesting discussion. And we have a panel of experts. They are really very experienced in their fields of working, research, and they are going to share what they think in the perspective of in which they think they can help to achieve universal health coverage, what we call UHC. And without really taking so much time, I may announce that this is a moment to reflect on what we have been done and what to be done differently to be able to achieve this UHC as well as SDGs in general. And generally speaking, SDGs has been put in place to fast-track global health and other indicators regarding various sectors, including MCH, environment, and even partnership, as we were talking earlier in the morning. And this pandemic has taught us another lesson, but it has also played a role as a game changer, as some speakers also talked about earlier this morning, especially in global health, as well as in clinical settings. So this session will highlight more about that, and also let's hear more from our drivers themselves. Please join me to welcome a team of panelists. I think we are missing 2 panelists. If they are around, please, they can join us. Professor Lamonek, or if he's online, let us know. And also Dr. Patricia Monte. If both of them are online, let us know so that we can also include them.
I'm online, Chair.
Oh,
I'm online, Chair.
That's very good. So with that, let me introduce Dr. Nurura. He will be our first presenter. Dr. Nurura is Nurura Awal, and apologize if I wrongly pronounce the name, is the health advisor of Water Aid Bangladesh and has been coordinating WASH and health intervention and discussions mainly with Ministry of Health and other key partners and NGOs. He's a member of the National Technical Committee on WASH and the Directorate of Health, and contributed to the development of several key national documents. It means the strategy for WASH in healthcare facilities, WASH guidelines for community clinics, national menstrual hygiene strategy, and national cholera control plan, etc. Dr. Awal is also the chair, the chair of WASH Working Group at Global Task Force for Cholera Control, GTFCC, and member of the representative team on cholera related activities or discussions from Water Aid. He also an executive committee member of the National CSA SAN in Bangladesh. Maybe he will talk more about this. Please join me, or I may ask all the audience to help me and pay full attention to Dr. Nurura and help me in welcoming him on the stage. And Dr. Nurura, the floor is yours. Thank you so much. I think you have a microphone near you. You can just come downstairs or whatever.
Thank you, moderator. I'm Nurullah Awal. I work with Water Aid in Bangladesh. I'm the health advisor there. So may I request the presentation to in the screen? So actually what we are going to share today from Water Aid, the perspective of WASH, how it contributes to universal health coverage. And we will surely share some experience from Bangladesh and also our works in some other countries. So next slide, please. When we discuss on the healthcare, so we are very sure that health is a state of complete physical, mental and social well-being and not merely the absence of disease or infirmity. So health is a comprehensive well-being. And we discuss on health, and at one time we just feel on the hospital, the technology, the diagnostics, the vaccine, the drugs, and sophisticated interventions. So when health comes to our mind, we think of all these things. Next, please. So actually, when we talk on this, we think that when we establish a hospital or healthcare facility, actually it will cover the population, it will create the service to the people, and it will cover the need of the people in that area. But actually, it doesn't exist. There may be a good facility, good healthcare facility, but may not have the amenities to cater the service properly. So there may not be demand from the community or the client. So there may happen that there is a very fancy, nice hospital, but actually people are not coming to seek service. So there is a gap, and that gap has been very nicely analyzed in the Tanahashi concept that I just showed here, that there are some hospital facility intends to cover the population, but actually a very small part of it getting the service, and they are really in the effective coverage scale. So, you are very much familiar with this three-dimensional diagram of universal health coverage, where actually we inherit this idea from the Health for All that adopted in 1978 by WHO, that health to be achieved for all by the year 2000, which actually did not happen. On many of the issues that we analyzed and researched, finally it was found that financial barrier is one of the major issue. But in the three-dimensional diagram, you see in the one part there is population to be covered, another part the service to be delivered, and another part is the cost that has to be paid to achieve the service. But the very important thing is the quality of care. And our presentation will really focus on quality of care, which has a clear relation with WASH within health perspective. And you also know that within the Sustainable Development Goal 3.8 clearly demonstrates the universal health coverage issue. So next, please. So on the UN declaration, high-level meeting in 2019, there was a discussion, and there was the decision came out that leaving no one behind, regulate and legislation, that is rules, regulations, and then the quality of care, investment, and move together. But the most important thing actually came up is the ensure political leadership. Earlier one, please. Ensure political leadership and beyond health. So our discussion will today focus on beyond health. So health doesn't mean the technology, not the service, doctors, nurse, and human resource development, but also WASH. So in this slide, you see that there is a very nice primary level healthcare center from Bangladesh, but they may not have the safe drinking water supply on site. They may not have the running water in the toilet. They may not have the hand washing proper options in the facility. And finally, the most important thing, the waste management, the cleanliness, mostly ignored in many of the healthcare facilities. Next, please. So when we talk about universal health coverage, then from Bangladesh, we are sharing our experience. In Bangladesh, we have about 20,000 plus healthcare facility, and we have around 14,000 in the primary level. We call it community clinic. It's kind of mostly outdoor facility, and healthcare, health promotion, health awareness. And the secondary level, over 5,000, and also at the tertiary level, nearly 1,000. So this is the basic structure of healthcare system in Bangladesh. WaterAid identified the most primary level healthcare center for our work because it has the highest number. And if we can ensure and show a model for WASH inclusive healthcare facility, that will really give the advantage to the people of Bangladesh, mostly living in rural area. So earlier slide, please. Earlier one. Go back. Please go back. So we made a survey in 2016 and 17 with support from World Bank, UNICEF, WHO, and WaterAid led the survey. And we found in the primary level healthcare facility, which is the biggest number, over around 14,000, and they have very much challenge of running water supply, and most of the healthcare facility has only one toilet, not gender segregated toilet, not toilet for the patients or clients, not for the doctors or providers. There was no running water supply in 50% of the facility. There was challenge for the hand washing options. And I think this is mostly the situation in other least developed countries or even some global, I think I should say like developed country. This is the challenge because when we did the 2019 WHO report, we found that over 1.8 billion people in the healthcare facility are actually getting this challenge of WASH, inclusive service facility in the healthcare facility. So what we did, please go back. So with these problems, what actually contributing to the non-functioning of the healthcare center. That is a major challenge. And also, when we include it in the governance perspective, we see that if there is no toilet, no water facility, the healthcare provider, the community healthcare personnel that usually don't come to office on time, she or he opens the healthcare facility later and stay there for a few hours and not every day. So these are the basic challenges that we face in the primary level healthcare center in Bangladesh. There is accordingly lower expectation on the client side. There is also very low satisfaction on the clients and beneficiaries, and also very less ownership of the people and the local stakeholders. And finally, sustainability is a challenge. So all this together we incorporated in our model, in our activity in the Bangladesh for community clinic. Next one, please. And we focused on WASH. So you see, as we said, that involvement of the local government and local leadership. So we included that approach in this WASH improvement in the healthcare facility. We included the local government, and also we tried to improve the water, sanitation, and hygiene. And they also provided some of the funding. People also provided some of the funding as well from the donor part. So they had the participation, they had the ownership, and also they provided the support for monitoring, supervision, and as and when required, maintenance support. So all this together, also we trained the management committee at the hospital. We told about their process to getting fund from government, how to run the healthcare facility, how to manage, and how to revenue generate. So altogether, actually, we made, next one please, we made the healthcare facility from non-functioning to function. So you can see this very primary level healthcare facility, and if it is a healthcare facility, the challenges are, it was with the timely opening, full-time operation, daily presence, that I already told, and the demand creation in the community. And if there is not many patients, there is very less supply of medicine. So from the other side, the government also interested to cater primary healthcare from this healthcare facility, but this is not really being approached or accessed by the community. So there is a gap. And when we improve this situation in the community clinic, we also incorporated different level of diversity healthcare. For example, delivery started to take place in the community clinic. There was nutritional activity. There was elderly healthcare. There was adolescent healthcare, MHM, and all these health promotive and awareness activity started within the primary level health center in Bangladesh through the incorporation of WASH. So next slide, please. So you can see the earlier structure and the renovated structure with WASH for a full or nearly full functionality of the healthcare facilities. Next, please. So this is a WHO diagram. Actually, they consider WASH in healthcare facility, it must be people-centric. That we did in Bangladesh, involving the community. So that is one that has been endorsed by WHO. Second thing is, Also the supervision, data management. On the right side, you see the importance of monitoring. Next, please. So there are some quotations here I have used. For example, on the left, you can see a quotation from a midwife from Malawi that the experience of not having proper wash or sanitation service in the healthcare facility. And for a delivery, a given mother has to go to a river to take the cleanliness. And also, we see that there is a quotation from one of the WHO director that a healthcare facility without wash is not a healthcare facility. And finally, the DG of the WHO, he said, if you cannot do the basics, forget the rest. Prevention, prevention, and prevention. So the universal health coverage concept, the preventive, promotive, curative, and rehabilitative, the most important part is the prevention, and WASH has the most, and I should say, the important preventive approach to cater the universal health coverage. Next, please. So actually on the right side, you see a very big queue. Lot of people are waiting there for taking service, but if it is in big screen, you could see most of the complaints are diarrhea, hepatitis, dysentery. So all these are water-related health problems. We could mostly avoid those if we would have investment in safe sanitation, safe water supply, and hand hygiene practice. Next, please. Next. So same way, we need to convince the policymakers on the importance of WASH in healthcare facility. Next, please. So in 2019, there was a WHO World Health Assembly, and they endorsed the WASH in healthcare facility resolution, which have a guidance how to do it and what are the elements to consider in improved WASH incorporation within healthcare facility. Next, please. So these are the different dimensions that we can really get benefit from incorporation of WASH, part of which I already have shared from Bangladesh experience. Next, please. Next. So among different benefits, we get an important agenda from WASH incorporation is AMR, antimicrobial resistance. If we have the WASH, proper WASH within the healthcare facility and within the community, we don't need to utilize unnecessary or overuse of antibiotics. That really is an emerging issue coming up, and we can really avoid it through investing in WASH. Next, please. So these are again the WHO and UNICEF response to the resolution upon that WHO 72 guideline. Next. Next. So these are the changes. Next, please. And also, again, I like to reiterate that WASH improvement or WASH inclusion has to be done through a health system strengthening approach. So that is one. Lot of issues are related for this work, but we need to focus on health system strengthening. Lot of agenda here to consider. Next, please. So you can see from some of our Africa works in different healthcare facility, improvement of WASH. Next one. We did it in Cambodia, and also we use the WHO situation analysis tool, WASH Fit facility improvement tool. So you can also think of that to understand the situation, understand the gaps in WASH. We need to do kind of situation analysis. And next one, please. Next, please. So thank you very much. And we have WaterAid guideline for WASH inclusion in the healthcare facility. So if you have more interest to know and want to know more, please communicate with our local WaterAid Rwanda office. And thank you very much for your patient hearing. Thank you.
Yeah, thank you so much, Dr. Nurura. And if you allow, maybe I can continue sitting. And I will not take so much time because we don't have really much time, and you know we have a little bit delayed. But just key point from his presentation, he just emphasized on the central role of hygiene. Actually, most of the healthcare facilities or healthcare workers, we always look at hygiene as something maybe minor in our daily work. But with this COVID-19, we have actually realized that WASH programs, hygiene-related activities, and behavior attitude can play a great role in dealing with this pandemic. So he really stressed on that. And another component of UHC he brought in is always leaving no one behind. The community-based interventions, how involve community, engage them in our interventions, especially for prevention. So he actually come back on the prevention as a key in our intervention, especially for dealing with infectious disease, among others. The role of policymakers is very key. The role of partnership, especially for financial availability. Those are the points we need to look at. And finally, the integration of WASH initiative in our healthcare facilities and our daily work as healthcare caregivers, but also global health researchers, experts, in whatever domain we are operating. So thank you so much, Dr. Noor, and please help me to again appreciate his presentation. So, for the matter of saving time, I remind the presenter that you have 15 minutes presentation, and please, I don't want to raise this paper near me. Maybe if I look at you, just know that the time is over. And maybe the audience, you can keep any comments, points. We'll have a Q&A session where you can ask or comment on any presenter's topic. So next, let me introduce the next presenter. Actually, he's Dr. Murthy Venkateswaran. Very difficult to pronounce. But today, he couldn't make it, but actually, we are lucky to be with his actual boss, I think. So Dr. Ezekiel Sai, the CEO of the Sanitas, and he will share with us the topic. He will talk about universal health coverage for East Africa. So Dr. Ezekiel, the floor is yours. Thank you so much. Please help me to welcome Dr. Ezekiel.
Good afternoon, ladies and gentlemen. Thank you so much, moderator, for giving me this opportunity to present this topic as in universal health coverage in East Africa. As you can see, the earlier presenters in the morning, they have highlighted some very important key points to note. One of them is quality healthcare should be the right to any human being. And if we need to make sure the quality healthcare is accessed by any human or any creature, we have to pay attention to what we call universal healthcare system, because we are doing so many models. But I'm going to present to you a model which I do think, if it's adopted across East Africa and probably Africa at large, it will enable our communities to have quality health, and eventually the nation is going to be healthy. Because if you have quality health, then you have a productive team, and you have the better people of the nation. Therefore, I will start by explaining a bit of what do we do in Tanzania. I come from Tanzania. I am the CEO of the hospital known as Sanitas Hospital, as you can see in the banners on the both left and right hand. And in Tanzania, the healthcare system is in such a way that we have a national healthcare insurance fund that is called NHIF in short. But also we have private insurance. We have the government. We have the cash component or the cash model. The national healthcare insurance is a monopoly in Tanzania. That means every individual, every institution in the government is supposed to enroll in the national healthcare insurance. But we all know that there are so many challenges right now in many governments in East African countries in terms of making healthcare, quality healthcare accessible to every individual, to every woman and man, to every child, and probably to every living creature. This is the challenge, and that's why we have done research and come up with a proposal which we think, if adopted, it could help combat many issues on health in the manner of accessing the quality health across Africa. If you look at Rwanda, a case study is back in 2003, they were less than 7%, but all the way to 2013, even now it could be more, they have gone above 74% in what we call community-based insurance program, health insurance program. And we have seen today that Rwanda is one of the best, probably the leading country in Africa in what we call delivering quality health to their people. And because they have adopted the better model within the universal health coverage. Now, in Tanzania, we have what we call fee-for-service. Fee-for-service is when the patient walks in the health facility, go to the registration desk, get registered, go to the doctor with a claim form from the insurance company, fill it, and go get treatment and go home. And the insurance has the job to raise the claim towards the hospital, goes to the insurance, raise the claim to claim for a payment. But this has a lot of loopholes of dishonest, and because it's after service, there is always so many of issues that happen along the way. Leakage and every other possibility of not being able to access the service to the client because missing of the medicine and other hospital consumables is an issue. Now, if we want to improve the quality of service to our clients, we need to go into what we call capitation model. And this is what I'm going to speak about, capitation model. Please, will you give me the slide? You could see that this is what I want you to pay attention to. That we have the universal health coverage in East Africa, but we are proposing a capitation model. Number one, if you look in Tanzania, is NHIF, National Healthcare Insurance. What we are proposing is this. Right now, allow people to register in the hospitals of their choices, because this will enable everyone to go to the hospital near to their homes, get registered. The National Healthcare Insurance is receiving premiums in advance. So the same should be done such that they do their mathematics so easy that they leave 10% to run their administrative cost, 90% divided by the members, and then see how many members have registered to which hospitals. Then they divide by 12. So they pay every first of the month. They advance the funding into the hospitals so that they can organize their supplies, they can organize their medicines, they can organize their facilities to make sure everybody who needs a healthcare attention has got it on time. There will be no question of no medicine. There will be no question of not this, not that in place, because there is funding in advance. So if you look at that, you'll see that there will be one provider for one person. If we talk of people living in rural areas, there are hospitals, there are districts, there are dispensaries, there are hospitals close to their homes. Right now, you're supposed to, not every health facility is accredited by the NHIF. This makes other people travel all the way, far away. They don't have money, they are sick, but they are supposed first to raise funds to travel to go to get service from the faraway hospitals. But there are facilities close to their homes. They need to be equipped. They need to be enabled to have every service available for the clients around. So that is what we propose to NHIF. And this, what will be the solution? The accountability will be the strictly following standard treatment guidelines. This is what should be the thing to look up. And you'll find that they have to reduce the number of staff who they deploy in the office, because there will be no paperwork. There will be no printing of tons, thousands and thousands of tons of papers, printing claim forms and buying other stationery materials. So this is what we propose it should be the case. Number two, you will find the private insurance. Private insurance should be the same, because right now the private insurance goes with the claim forms, same as NHIF. They also do the same. They receive premium in advance. They should allow their clients to register with a hospital of their choice nearby their homes. Then they run the calculation as they have received the premiums. And then they pay every month in advance. So what remains their role is to monitor and control the service provision, but also to make sure that everybody benefits. Right now, they are lacking clients. In Tanzania, private health insurance are almost at the brink of closing down, because the national healthcare insurance has almost taken every client. Their premium is very low, but the quality of service is very poor. So it needs to be improved. So they have to go with the same capitation model. If you go to number 3, we have social security funds is another model. We should scrap the current capitation model for OPD and IPT and move to the same. And for them, it is very easy. There's no contribution from the clients. They divide by 12 and then divide by the number of clients. Then they find that every facility registered, get the funding in advance, they organize. There are so many advantages that you will see in the end. Number 4, we have the government. The government hospitals should be run like state-owned enterprises. This is actually what should be happening. And those people who are not able to pay or who are not employed should be enrolled, and the government should pay to the hospitals that they have chosen to be treated to. And this will make the government more accountable, and the donors, instead of giving money to these NFPs who actually take advantage in the name of NFPs, they should choose the mission hospitals or other service providers and allow them to register the members and get the list of members registered and pay the capitation also to those hospitals. This way, improve, and it makes them more accountable. See, they are taking advantage. I'm against the funding, the donors giving funds to non-for-profit organizations that are taking advantage, and there's no clients getting treated in there. You go, they are barely empty. So this way, it makes them more accountable, because there must be members registered with those facilities to receive healthcare service. Number 6 is cash. Cash stays as it is, but we will encourage them to enroll with either private insurance so that they will save more money, because paying cash is expensive. And number 7, informal sector, we ideally encourage that they go through the same way of enrolling into the national healthcare insurance, but because they are small businessmen and women, they can access micro loan from the banks, and they can go towards accessing the quality healthcare from either the national healthcare insurance or from other private insurance. Overseas insurance, they stay as they are. We attend them. Their system is better. And what is the happy side effect of this? If you look at everything, you'll find that there is honesty in it. What will be the role of a service provider? They will move more on the side of prevention than treatment, because they have funds. They can organize their facilities better. They can make the medicine accessible, and they can pay their staff in time, and they make them happy. See, they have to make the better environment for prevention, because they have to save for upgrading their facilities. This way, you'll find majority are investing more on prevention than on treatment. Right now, we are waiting for people to get sick so that we treat and claim. But if you have money, you plan the prevention methods such that you don't have to use entire money you have received in purchase of medicine and other medical consumables. This way, the quality of health will be improved in the nation, and eventually you'll have healthy people. All records in one place, because everyone chooses the hospital of the choice, so that way their confidentiality is observed. You see head-to-toe service. The role of the provider is to 100% take care of its wards. That is the advantage. But preventive care, as I said, and there will be no paperless completely, as it is of now, and all medical staff. See, in these insurance companies, they have employed a great number of medical doctors and nurses who are going to assess and be judges on the papers. If these people are diverted into the medical field, they will do the job of which is appropriate, instead of going to sit and say, oh, how do we deduct where a mistake was done, and then we can deduct. So instead of that, they will now focus on doing an appropriate job of their choice. Now, and lastly, providers will become world class, because the improvement of the facility, there is purchase of medicine and everything that's needed, because what remains with the government and the insurances is to look towards the quality of service that is given from the providers. This is what we call capitation, and this is what we need to make sure that it happens. We have more ways of doing this. We have so many slides to explain about this, but I have given you a nutshell on what we think the right model within universal health coverage if adopted in East Africa. Thank you.
Thank you so much, Dr. Ezekiel, for a well-elaborated presentation. And actually, when I was looking at it as a medical background person, I was thinking, oh, this is a neuron. Those who did medical school or biology, this is like a very unique way of presentation. So thank you so much. And I will not really into deep detail, because this is very special sector to me. But I have just highlighted some few points, such as UHC for East Africa. And this is remind me, how can we customize all our global interventions or policy or plans or those kind of agreed points to our local context. So that was my first point I just get when I saw the topic. So we should think about our community, what do they need, and what are the reality in our local perspective, and then try to customize whatever interventions we have to do. And second, of course, he talked about capitation. And this capitation has very wide components. The role of government, NSSF, donors. Actually, in Rwanda, we call them partners or development partners. We no longer call them donors. And cash, private insurance, all those key players, stakeholders have a great role to play so that we can achieve this UHC. And also, we should not wait for people to get sick. Whatever intervention we want to do, whatever activity or project we want to think, strategy, we should not really wait until people get sick. And prevention, community awareness, education, and then also saving for the finance when it comes to the health financing. That is really very important. So those are the key points I have highlighted, but I know you have also more you can discuss with him in our Q&A session. So on that note, thank you so much, Dr. Ezekiel. And as I said, he was presenting on behalf of Dr. Murphy, who could not make it, but I think we are also lucky to have him as the actually representative of Sanitas Hospital. Thank you so much. On that note, let me now call upon the next presenter. I think he's online. He's Dr. Lamnek Ahuluwalia from South Africa. He will share with us the topic on delivering routine universal primary healthcare services to youth in post-schooling education and training in South Africa during the COVID-19 pandemic. So if you allow, let me just briefly introduce him. Actually, I'm very sorry, he's Professor Lamnek. So Professor Lamnek is just a second.
Chair, I can save you time and I can explain a little bit very quickly.
That's okay. So now, yes, I was struggling to recover the bio. So Professor Lamnek is a seasoned, trained, and qualified physician and health systems policy management specialist. And he possesses qualification of MBBS, actually called MBCHB, with 3 years postgraduate training in internal medicine, DNB. To augment his management experience, he has an MBA gold medal from University of Cape Town, assisting him towards a multicultural work experience in 4 diverse countries: South Africa, Germany, India, and Mauritius. Further, he also has a PhD that has assisted him in building a large number of significant diverse health programs in both developing and developed world, with absolute scientific and epidemiological knowledge and experience. In his current job as a CEO of Higher Health, the organization looks into health, wellness, development needs of all public universities, technical college, vocational college, community college, private higher education institutions, work and skills-based learning institutions across South Africa. Maybe to cut it short, Professor Lamnek also serves on several boards of various governmental and non-governmental organizations. At his capacity, served as health expert on the South Africa delegation for BRICS, which means Brazil, Russia, India, China, South Africa Academic Forum. He has addressed as a speaker at conference, forum, symposium across the world, and actively interacts with local and international media. And we are really honored today to be with Professor Lamnek, and please join me to welcome Professor Lamnek on the floor. Professor Lamnek, the floor is yours. Thank you.
Thank you, Chairperson. I just wanted to ask you if I'm audible and I'm clear, and is the voice quality fine? Because I'm online, so I wanted to check from you, Chair. Is it okay?
Definitely.
Chair, thank you. I will also share some slides, and I would like you to please also let me know when the slides are visible, and I will do that. But before I share my slides, Chair, before I go into how did we achieve universal health coverage for a very important population in South Africa, which is our next economy, our future, which is the post-school system, in trying to get access to health during the COVID pandemic, I will try to touch briefly on Africa as a continent and its relevance to why it needs to focus on the post-school system if it has to achieve universal health coverage. And that will be a little bit of a start that I will give. I'm sharing my slides, and please let me know if the slides are visible, Chair, so that I can move them. Thank you, Chair. And Chair and everyone, greetings from South Africa. And sorry I could not be in person. But this is how the world has given, this is how God has made the world. And this is how a beautiful Africa as a continent looks like. But if I start looking at diseases, let's say infant mortality, and compare it to the rest of the world, this is what happens to Africa comparative to other parts of the world. And you can see China, India, United States around us, Brazil, Russia, and Europe. And then look at HIV when we talk about it. We can't talk about universal health coverage when we do not talk about certain pandemics that the continent of Africa deals with. And this is what happens to Africa. And look at South Africa, and look at Southern Africa and how it swells predominant, including West Africa. Look at malaria. I'm picking up certain diseases. This is all the data from the disease perspective it put together around the world. And look at TB, when I wanted to show how the world looks like and how Africa behaves compared to other parts of the world. And now start comparing it with education system. When we talk about primary education, the entire world starts coming. Look at Europe, look at United States, and how smaller our Africa becomes. And then we talk about secondary education. Africa starts going smaller and the world becomes bigger. And this is what I'm talking about, tertiary education. And this is what Africa goes through, and the whole world swells. Similarly, science research, and similarly, patents. And if we don't change this, we will not be able to win a universal health coverage. And that's the first message. And this is what we inherited when the COVID pandemic hit the African continent, and presumably going to continuously hit us due to our low vaccination coverage, and we still formulating our policies and figuring out systems while the world moves ahead. And Africa needs to change this. And I know, as being an African, it is tough for me to explain this, but we need to understand our weaknesses so that we can solve our weaknesses. This is not to discourage us. This is to encourage that this are the challenges that Africa needs to push into in order for us to achieve the universal health coverage. And it needs a very strong scientific system. It needs a strong higher education. It needs a strong post-school system. In South Africa, 2.5 million young South Africans every year enter into a skills economy. So right from a plumber, a miner, electrician, doctors, engineers, managers, scientists, any skill, right from a tire puncher guy in the roadside, carpentry, it's produced with a skill. And that's how the world economy grows. And that's how African economy grows. That's how South African economy grows. South Africa will attract Germans to invest further in South Africa. It will invest Americans to do South African own investment and African own investments, because it has the skills or the manpower or a human resource to do it. And that can only be possible if these young people in the post-school education system understand health, understand well-being, when the world in Africa is surrounded by so many pandemics affecting the youth. Africa is a young continent. Our median age is of 18 years. South African median age is about 26 years. We are a youth continent. And if we have epidemics and pandemics affecting our young people, and if young people die before older people, then we have a problem. We have a problem of continuity and sustainability. So these are the issues that we need to look into universal health coverage, which South Africa is doing, and which I am responsible for in South Africa, in preserving our youth economy and bringing universal, easy, free access of health to this very key population from the very tender age of 15 years onwards, which is high school and post-school together under my care, in order for us to have an economic dividend that pays off when it goes to business, when it goes to government jobs, or when it goes to employment. Because in Africa, we are a single per parent who earns for the whole family, and we call it as a black tax. If this person dies, the whole family system comes up, because we are inheriting a very difficult past as a continent, being colonized, being being captured for a very long time. And only now is Africa as an economy moving up. And this is the same time the universal health coverage is coming, which means the population currently is very disadvantaged and doesn't have access to health and it doesn't have access to education. And this is the time for us to transform Africa at this stage. South Africa has got 8 million young people living with HIV. It is a huge problem for our country. TB is our third biggest disease in South Africa, and we are very mindful of our challenges. We have a very high rate of teenage pregnancies and unplanned pregnancies, to a level that 1 in 3 girls in schools or in institutions of higher learning become pregnant on campus, which means we need to fight through contraceptive programs, through properly sexual reproductive health, in bringing access to universal health to fight this stigma, because at the end, 33% of our economy drops out because they become pregnant. And by the time they realize at the age of 17, 18, 19, they cannot do abortions. They do not have the money for abortions. And at the end, they end up conceiving. We have a massive challenge of gender-based violence. It's not a health epidemic, but it is a huge social, economic, and health pandemic around the world, including Africa. Patriarchy, if I say 1 in 3 women are raped before the age of 21, if 1 in 2 women in Africa faces sexual assault, we have a deep problem. And if we do not solve these through access to health, through access to social support, we are not going to transform the continent. We have an underlying pandemic called mental health, with the massive stigma in African continent, with people not talking about this, with the youth affected with this. We are not transforming a pandemic of mental health. And in COVID, if you ask me, a single pandemic that has taken another extreme is actually mental health. 65% of our youth in South Africa are suffering from moderate to severe mental health issues due to the COVID impact. There's bereavement in the family. There is a loss of study times. There is economic challenge, parents losing jobs, and then exam pressures, hybrid model, finding ways of coping with education. These are real South African challenges in this world. And I'm not going to define only South Africa. I'm going to take Africa in general. 5 to 7% of our population in a post-school system through our studies have shown is to be LGBTQI. And only 30% of these people go into economy or skills because most of them get HIV. They have alcohol and drugs. They are stigmatized. And these are one of the most intelligent human brains we have. So stigma in Africa will kill 5 to 7% of our population just like that, because if we do not focus on access to support to these structures. 17% of our total population is disabled. And if we do not have focused interventions on disability, every disease, HIV, mental health, sexual reproduction, they all end up to disability. So disability has to be looked into a holistic approach, and we need interventions to support disability, because we lose 17% of economy because of health coverage not being focused to prioritize to a population that deserves it. Drugs and alcohol. When you are poor, this is a very easy route of an epidemic, and youth through peer-to-peer influence comes very excessive. So how does universal health coverage in Africa challenge this pandemic? And to above all this comes COVID-19, a virus that's beautifully formed a human-to-human transmission, mutating. In fact, tomorrow I'm releasing results in South Africa on the 4th wave in South Africa, and how we're predicting the 4th wave and how it's going to affect the business continuity in academic year. Because now we know this virus, we know the predictability of this virus. We understand the genomic variations of this virus and its level of mutations. And how does a vaccine and the escape mutations will affect the future of this pandemic? Because we know COVID is going to become endemic, and that's where we need to do. So these are all integrated pandemics in Africa. These are not different. You can't deal HIV without dealing with alcohol and drugs, or disability, or LGBTQI. You can't deal gender-based violence without mental health or drugs. These are all interconnected. So a universal health coverage has to be an interconnected approach. And I wanted to show you realities. This is not an African problem. There's a problem in United Kingdom. There's a problem in United States. There's a problem in India and Brazil. So it's not our problem alone, but we need to admit that we have a problem. And if we have to admit the problem, we need to do something about it. So I'll go straight to what we need to do and what we are doing in South Africa. We are tackling it through education. We do not believe there's anybody more powerful a tool in prevention than education. We can't let our population suffer with HIV. We need to first invest in prevention. The continent of Africa and the governments in Africa are struggling. They try to invest to react to a problem rather than investing towards prevention. Germans put 10% of their entire GDP into prevention. That's why they prevent diseases. That's what Africa needs. And how does prevention happen? It's no rocket science without education. In every institution in South Africa, whether a university, a college, a next skills development, you have an extramural curriculum run by Higher Health. 1 million South Africans enroll into this curriculum. A curriculum on GBV, a curriculum on mental health, HIV, disability, all the 8 areas I spoke. And when they enter the curriculum, it's peer-to-peer, it's interactive, it's not for exams, but you get certified. You get the certificate which helps you in jobs. It attracts you in incentives. But one exam you have to do is to do a risk assessment. If you are in an HIV class, you do a risk assessment on yourself for HIV. If you are in a gender-based violence class or in a mental health class, you answer binary questions like, have you lost interest and motivation? Do you avoid people? Do you think about a plan to kill yourself? Have your sleeping patterns changed? A 16-year-old, an 18-year-old, a 19-year-old emphasizing abuse in the house, understanding this in a class and answering for himself. And then trying to link to care, gender-based violence. Have you been forced to have sex against your will? Were you ever forced to have sex because you or someone in your family would be in physical danger if you refused? Forceful sex. In South Africa, 56% of our youth think that if you are in a relationship with somebody, forceful sex is possible. In South Africa, we are trying to bring universal access. So we believe in bringing health to the people rather than people to the health. Those young person is going to walk 12 kilometers to a health facility for its health. If you want to win youth, you bring the services to them. And that's the only access to a health model that works in community, whether it's higher education, whether it's basic education, whether it's communities. We are forgetting, before 1986, my father used to get a blood pressure medicine in the community when a mobile clinic used to come. I go to any part of Africa, we have lost the plot in this regard, and we need to change universal health coverage in that regard. We need to capacitate systems. I can go through a lot into this. We've got 24-hour helplines, but this works. Mobile health services, 24-hour helplines toll-free for mental health, bringing services on HIV testing, blood pressure. We have through our anecdotal data of 1 million students doing blood pressure checks last year, we had 10% of the population before 21 is hypertensive. We have another challenge in South Africa called obesity. We only started finding out when we started bringing the services to the people at early stages. So investment in health is needed, and technology has to help us. For COVID, we put technology. We had an issue called, how will we screen 2.5 million students entering our system every day on a COVID screening program? It's a government regulation that you have to check. And it's important because that's how fast this virus spreads. But you can't be screening through humans on the gate when you have 5,000 people standing in a queue outside. You're causing congestion and causing people to get infected. So you use technology. We built this application in a month. It started issuing passports. Everybody does their risk screening of symptom screening every day. Now they're doing for vaccines also. And they're issued a passport. If they issued a passport, they show on the gate, they have an expiry of 24 hours. You're in the system very quickly. So technology made. And what happened immediately? 16 million passports have been issued. 1.6 million youth are into the system. This means I am in one button touch with 1.6 million youth on any issues. What we are doing now, we're changing to HIV. We're changing the same thing to SRHR, mental health, GBV. The aim is to destigmatize the disease, to talk about this and build a culture of health among the young people at the stage of 18 and 19, because this is our hope. They're coming from broken families and single mothers and seeing abuse. But if they form a family and they have their children, they understand health and well-being from the beginning and earn for Africa, then the next generation of Africa will transform into more stability and the economic growth will automatically happen. So health is the root for economic growth and GDP. So take that into this. I won't bore you others. I've got enormous slides, but thank you very much for allowing me. And it's a pleasure speaking to all of you. Thank you.
Thank you so much. And Professor Ramnek, I'm very sorry to cut you short, maybe because of time, but I think you have already elaborated everything you wanted to share with the audience. And ladies and gentlemen, please help me to give another round of applause to Professor Ramnek. Although his also topic is quite interesting and strange to me, but I kept some points, especially leaving no one behind should go with targeting all ages. It means most of the time when we hear UHC, we think we target remote area, community, very far, instead of cities, but we should also think about ages, young people. They are actually the next generation. So we need to empower them today. And secondly, the inclusivity and diversity, especially remembering some more components which we may think they are neglected, such as mental health. We cannot achieve UHC without being exhaustive in all corners. Investment, we need money, of course. We need private sector in everything. And technology, such as health check, as he mentioned, especially for this pandemic, we have really learned a lot that we should not really always think that the patient has to come to hospitals or clinics. Why? How can we educate our population that remote medical diagnosis, checkups, and consultation is really possible in terms of MCH and other diseases. So those are the messages I kept. And I think if he allows, I can read his conclusion. In the face of continuously unfolding global pandemic, COVID-19 response interventions need to leverage on and incorporate existing programs, systems, and capacity to ensure the gains realized in responding to epidemic such as HIV and TB are not reversed. This is a great lesson, and actually even for COVID-19. We have built a huge capacity, but it's unfortunate if it can really go with COVID-19 and then beyond, we don't even think further. So this is a take-home message. So as I said, I know you have many questions, but please hold on as we introduce the next presenter. And I have looking around and I see some people start sleeping. Maybe it's because of the noon. Can I, if you allow, can I ask everyone to stand up and stretch a little bit? So if you can, take your paper or your notebook and a pen and face your neighbor, either right or left. So please take a paper, pen, face your neighbor, left or right. I don't know, Dr. Falter, who will you look at? Maybe this one. So please look for the neighbor. And look at his or her face. Take your notebook on your head like this. Please allow me to do that. It's not undermining, but just making you energized. And take your pen on top of the paper. Start drawing the face of your neighbor. And please draw it carefully. Especially those who are drawing the faces of ladies, please pay attention. It takes 5 seconds to draw that image. Only 30 seconds. Please abide to my regulations. So if you are done, please can you show your neighbor what you have done? So thank you so much. Please have a seat. So now allow me to introduce the next speaker. Actually, maybe she will be the last one. If Patricia Monte is not around, not online and also in the room. The next speaker will be Mrs. Faustine Uwingabire. I'm not sure if I can say registered nurse, if she allows. She's a registered nurse. And she will share with us a topic on investing in nursing and midwifery to achieve universal health coverage and SDGs. Mrs. or registered nurse Faustine, she's actually a neonatal nurse specialist with a Master's of Science in Nursing. She works at Partners in Health in Nshuti mu Buzima as a neonatal nurse clinical mentor. A position she took after 10 years working experience at University of Rwanda School of Nursing and Midwifery as a nurse educator, as well as a nurse leader and coordinator of various nursing programs. Mrs. Uwingabire is the President-Director of Rwanda Association of Neonatal Nurses, RAN, as well as active member of Rwanda Nurses and Midwifery Union, NNU. She's driven by values of integrity, quality, advocacy. Her vision is to save newborns' lives through knowledge, skills, sharing, mentorship. And Uwingabire is the winner of COIN, C-OIN, Neonatal Nursing Award at Auckland, New Zealand in May 2019, due to her contribution at national and international level. She's a self-motivated person ready to advance her neonatal and leadership career. Please join me by welcoming Mrs. Faustine. The floor is yours. Thank you. And I remind that you have 15 minutes. Kindly use it very well.
Good morning. Thank you very much for the occasion to present about the needed investments in nursing and midwifery in order to achieve the universal coverage as well as sustainable development goals. Nursing is the backbone of every effective healthcare system, and we found nurses and midwives everywhere in all settings, including the settings which are very hard to reach, and most often they will be the only one available healthcare professionals to care for the population there. Their contribution goes beyond just caring for the sick. It goes to preventive and promotive cares. Next. Nurses serve 24/7 in almost all healthcare settings, and they are one of the most trusted roles in the society. Their needs are across the globe. Unfortunately, with disparities and unequal distribution as all other good investment in health, and the major burden is held by lower and middle-income countries, especially very remote settings. WHO in the 20 World Nursing Reports highlight the gaps in terms of nursing workforce. The gap was identified at 6 million nurses missing in the healthcare systems, going to around 10, adding more other 4 millions in 2030 through nurses aging and retiring. But we are not including the effect of the COVID pandemic, which was not measured in those statistics, meaning that the globe is really in huge need of nursing workforce. And when we say 6 million nurses, it it is around 6 billion populations who are not accessing care because nurses are not there. Next, please. What are the most challenges? There are many. We come from different countries, and nurses here may speak differently, but the cornerstone of the nurses' challenge is about the weak regulatory environment. The weak regulatory environment, in some countries, there is no nursing representation at national level, meaning that nurses' voices are not included in health policy making. There is bias around the role of the nurse, and it starts very early. I do remember my kids from nursery. Once they come to study some social roles, they bring a picture of a nurse with a needle. So the population know that nurses give injections. They stop there. There is nothing around prevention, nothing around promotion, nothing around monitoring, nothing around assuring patient safety. And that bias contributes wrongly to the right investment in nursing workforce. There is issue of defining nursing needs based on numbers, instead of basing on the responsibilities and roles. So if roles and responsibilities are not known, you will not be able to invest properly in nursing, because people may be thinking that I have 10, and they think 10 is enough because they are comparing to other cadres, but they're not incorporating what the population needs from those nurses. So if they really measure the responsibilities and workload of nurses, they will know how to accurately invest in the needed number of nurses. We have an issue of standardized healthcare services. This one is protective on one hand, but also not beneficial to the population, because we seem to think that everyone will receive the same package, regardless of attending to their individual needs. And most often, nurses will attend with non-calculated hours, because they don't just care, but they enter into a healing process relationship with the patient, even with the family. There is also misunderstanding about nurses' advanced role. Even in Rwanda, where we do have a master's, even a PhD in neonatal nursing, but we still have even people with high literacy asking what a master's nurse will be doing, what a PhD nurse do. People seem to think that nurses are just general nurses, but the population needs goes beyond just general care. It goes to nursing specialized care. Nurses or nursing and SDGs, people may think that nursing will just be tackling on health-related SDGs, but their work goes beyond that, because we have 5 Ps as pillars of SDGs, which are people, prosperity, planet, peace, and partnership. But among the 5, people are in the center. So healthy, well-being, population is needed to drive the rest. So nurses' work contribute beyond just health-related SDGs. Next, please. But if we go inside those SDGs to identify SDGs with a determinant of good health and well-being, they are close to 17. So nurses' contribution goes beyond. Remember the morning they were presenting about making more drugs. If nurses are not there to ensure they are effectively used, the work will definitely be